Oncology permission, sir. I'm starting with today's session now. Greetings and a very warm welcome to all the dignitaries present here. I am Shwastika from Team Clarnet, serving as the allocated session assistant to ensure a seamless experience. Clarnet is India's most trusted and widely used digital platform offering a multitude of enriching services exclusively for the doctors. Clarnet is delighted to be chosen as the digital partner for this event organized by Indian Pharmacological Society. So today's focus would be online workshop on pharmacokinetics. Let's begin today's session, for which I would like to invite Dr. Shambo sir. He holds various esteemed degrees such as MBBS, MD, and he is a consultant physician, diabetes and allergy asthma therapeutic specialty clinic, Kolkata, faculty
We
JMN
can start.
Medical College. Over to you, sir.
Yeah, thank you very much, Clarnet, for being the academic partner of today's event. And good afternoon, respected chairpersons, distinguished faculty, and dear postgraduate students. Let me begin with a simple clinical situation. A 65-year-old patient with sepsis is admitted to the ICU. The correct antibiotic is prescribed. The dose seems appropriate, yet after 48 hours, there is no improvement. Now the question is this only antibiotic resistance, or is it a failure of our knowledge on pharmacokinetics? Sometimes it is not the drug that fails, it is our understanding of how the drug behaves the body. So that is exactly why are we here today attending this fascinating workshop. So this workshop is organized by clinical section of Indian Pharmacological Society. Myself, Dr. Shambo Samrat Samajdar, Secretary Clinical of Indian Pharmacological Society. Our society is one of the oldest and most prestigious pharmacological society in India, with strong academic foundation and international recognition. We have leaders like Professor Babul Bejborua, our respected president of Indian Pharmacological Society, Professor B. Kolakumar, the General Secretary of Indian Pharmacological Society. Today also we have Professor Debashish Hota from AIIMS Bhubaneswar. Currently he is the chief editor of our prestigious journal, Indian Journal of Pharmacology. So IPS has consistently played a pivotal role in advancing pharmacological education, promoting research, bridging the basic science with clinical practice. So for all the postgraduate students and young faculty joining us today, I would strongly encourage you to become the life member of Indian Pharmacological Society, because IPS is not just a society, it is a professional community that will shape our academic and clinical journey. Now, let me ask you honestly. We all studied pharmacokinetics in our first year. We memorized those terminologies, those definitions, half-life, clearance, volume of distribution. But today, if you want to visit your words, how often do we actually use this concept very confidently, especially when adjusting doses in renal failure, when interpreting drug levels, when deciding antibiotic strategies? Too often, pharmacokinetic becomes a set of formulas for our exams, not a tool for patient care. So today's workshop is designed to change that. For an example, if a case of a renal failure, a patient with CKD develops drug toxicity, you reduce the dose. but the toxicity persists. Why? Because dose of a drug is only one part of the story. Because we need to acknowledge clearance has changed, half-life has prolonged. So if we don't understand pharmacokinetics, we treat blindly. Similarly, a ICU antibiotic failure case, a critical patient is receiving antibiotics, lab reports say sensitive organisms, but clinically there is no response. Why? Because the drug concentration may not reach that effective level we want. That is why we need to know the concept of area under curve by minimum inhibitory concentration ratio, that concept, because most probably that AUC by MIC, that targets are not reached. Pharmacokinetics here is not theory. It is the difference between recovery and deterioration. We need to know that. For an example, if we talk about an elderly patient, comes with dizziness and confusion, multiple drugs, all drugs prescribed in a normal doses. So what went wrong? We need to know there could be increased volume of distribution, reduced clearance, altered protein binding. So same drug, same dose, but completely different outcome. So what will you gain from today? By the end of this workshop, you will be able to understand, interpret plasma concentration time curves, calculate and apply those slope intercepts, elimination rate constant, half-life, volume of distribution, clearance, accurately estimate area under curve using those trapezoidal rule. And also you can apply this pharmacokinetic knowledge in oncology care, antibiotic stewardship, geriatric prescribing. More importantly, you will stop seeing pharmacokinetics just as a mathematics and you start using it as some clinical reasoning. A small request to all of you, do not approach this session as a just lecture, approach it as a clinical problem solving exercise. Ask yourself at every step, like, how will this change my prescription, my advice tomorrow? Because ultimately, again and again, we want to reiterate, pharmacokinetics is not about equations, it is about precision in patient care. So we have an excellent line of speakers who will take you from basic concepts to real world application. So let us begin this journey from numbers on paper to decisions at the bedside. Thank you all. So it is our real privilege to introduce Professor Anant Patil. Professor Anant Patil needs no introduction because he is one of the prolific speaker, prolific teacher in the field of pharmacology, and he is one of the very renowned pharmacologists who are governing different guidelines. Especially we need to appreciate his contribution on urticaria management guidelines. So we are really delighted to have you, sir, with us now for next, I think 3 hours is yours. We are really delighted to have your teaching, sir. So over to Professor Anant Patil.
Okay, so very good afternoon. So thank you so much, Dr. Shambo, for the kind introduction and setting the tone. I also thank Dr. Devashish Hota sir for being here and sparing his time on the Good Friday. So as Dr. Shambo mentioned, that let's look at the pharmacokinetics, not just the numbers or the calculations. How do they make sense in terms of the clinical practice? So the lineup is excellent. So I will be speaking about the basics of pharmacokinetics and the calculation part. And then there are sessions from the experts on the clinical application of this. So let me present my slides, and once Dr. Shambo tells me that the slide is visible and they are moving, then I can begin.
Yes, sir.
Perfect.
Moving, yeah.
So you
So
can
maybe,
proceed now. Yeah.
yes,
Yeah.
thank you. So maybe next 2 hour 45 minutes is what we will be discussing about pharmacokinetics. And this is what would be my agenda. Although it is written lunch break, but hopefully we all have a lunch already. So without break, we will be continuing everything. So the first thing that I will be talking about, what is the need, and I think Dr. Shambo has already spoken about what are the objectives of this workshop. So I will not go into the objectives in detail. Before we go into the calculation parts and the definitions and the relevance, we will revise pharmacokinetics in nutshell. So that will take about 25 minutes approximately. And then actual the concepts called as intercept, slope, and some of the mathematics. Because today's workshop is not just pharmacology. It's a combination of pharmacology, statistics, mathematics, and importantly, I have designed all this calculation based on the Excel sheet. So it's a combination of four things: pharmacology, mathematics, statistics, and Excel sheet. Some formulas which are given in the standard textbooks, those we will revise them, and then we will use them for calculation purpose using Excel sheet. So what we will be doing is we will be talking about the area under curve, how it is calculated by different methods, and I will demonstrate you how to calculate area under curve using the trapezoidal rule. And then using Excel sheet, I will also demonstrate how to calculate or the how to plot plasma time concentration curve, and also how do we convert that plasma time concentration curve into log plasma concentration time curve. Then we will calculate slope, intercept, concentration at time zero, volume of distribution, and all of those. Uh, because it's a virtual workshop, maybe hands-on experience may not be possible today. So we'll stop at the agenda number 7. So that is the plan for the next maybe couple of hours. So introduction has already been given. Objectives briefly now. So what we will be doing is describing first the different PK parameters and then calculating those PK parameters. And as we speak about those PK parameters, the relevance in therapeutics will also be simultaneously spoken about. And one of the important things is that India is considered as the capital of generics of the world. And we have a lot of BAB centers. So how do we demonstrate bioequivalence of one generic product versus the reference product? And by giving some raw examples of the raw data or the dummy data, we will see that how the bioequivalence is defined and how bioequivalence is shown actually with the calculation. So that's the plan. Now, the actual agenda starts from here. And I'm going to speak about pharmacokinetics in nutshell. Although I will not go into details, but whatever is relevant for today's discussion, only those things I will be just revising. Most of you are the pharmacology residents, and I'm sure everybody in second year has studied pharmacokinetics. But in residency, we have to learn little more in detail, and only those concepts I will be speaking here in agenda number 2. So this couple of figures that I have taken from the standard textbook of the Essential of Medical Pharmacology by K.D. Tripathi sir. And I will be speaking about these terms in relevance to this graph because these graphs and the concepts are useful in the calculations. So this is what is called as the plasma concentration time curve. Now when I say plasma concentration versus time, on the x-axis you can see there is a time, and on the y-axis we have a plasma concentration. Now I can take the plasma concentration as it is on the y-axis, or I can also convert this plasma concentration into log concentration, and we will be discussing when to convert that into log concentration and when we have the plain plasma concentration. So just to reiterate, this is the plasma concentration versus time curve. Now there are three formulations which have been shown here. Formulation 1, which is A, formulation B, and formulation C. And there is a dotted line which is horizontal called like the therapeutic concentration. Now we can see and we can very well appreciate here that the drug A or the formulation A has crossed the therapeutic concentration. However, the product B and product C, they have not reached the therapeutic concentration. Now, obviously, the drug A is going to show some action, whereas drug B and drug C, they may not show action because they have not reached the therapeutic concentration. So now, having understood the simple graph, let's talk about what is Cmax, what is AUC, what is bioavailability, what is Tmax, what is half-life, the minimum effective concentration. You can see here this dotted line is nothing but the minimum effective concentration. And we can have another line somewhere here, which could be minimum tolerable concentration. And there's a concept called as therapeutic index. So let's go one by one. So the Cmax, when we draw a perpendicular line on the y-axis here. So if I can draw the line here, if I draw this perpendicular line here, then this would be the concentration, which is the maximum concentration achieved by drug A. Same thing we can draw for drug B and drug C. So this is called as the C max. Now, how much time drug A has taken to reach the maximum concentration? If I draw a perpendicular line here, it would be called as the T max. Same thing I can do it for formulation C also, formulation B also. So which means that the C max is nothing but the maximum concentration which is achieved, and the time taken to reach here is called as the T max. Now the area under curve, this concept, area under curve, there are two aspects to the area under curve. Or maybe the definition of bioavailability, if we define first, then we will understand what is the relevance of the AUC. So there are two definitions of bioavailability. One definition is called or maybe defined as how much drug reaches the systemic circulation and that's available for action in unchanged form. That's called as bioavailability. The second definition probably is more important when we talk about the bioequivalence. So the bioavailability of, say, product A, if I want to calculate or define what is bioavailability of product A, I need to know two things: the rate of absorption and the extent of absorption. So what is the rate of absorption is how quickly the drug is reaching the level. That's the rate of absorption. The extent of absorption is how much drug is reaching the circulation. So area under curve is talking about the extent, and Cmax and Tmax, they are relevant for the rate of absorption. Now when we say bioequivalence, now suppose I have to compare the bioavailability of drug A versus drug B. And as I said, bioavailability is rate and extent. So if I want to compare the bioequivalence or check the bioavailability comparatively between drug A and drug B, I need to know what is the Cmax of drug A and what is the AUC of drug A. Then I will calculate what is the Cmax of drug B and AUC of drug B. And I will compare both of them, whether A, area under curve, and Cmax of A and B, they are similar. Now when I say similar, they may not be exactly same. So there are some maybe margins which are approved or which are maybe accepted by the regulatory authorities. So we'll speak about that when we talk about the bioequivalence calculation. Now the next concept is the half-life. So there are two words here again. One is a half and the second one is life. So basically half-life is a time, life is nothing but a time, and half is 50%. So it's a time which is taken by the drug to reduce the concentration to 50% of its original value. That is called as the half-life. Now why half-life is important? Because half-life has several implications and importances in the therapeutics. Number one is how much time the drug takes to get completely eliminated from the body. Now generally it is said that about 5 or maybe 4 to 5 half-lives are required to almost eliminate the drug from the body. Not complete, almost all drug. Because in one half-life, 50% drug will go away. In the second half-life, 75% will go. In the third half-life, 87.5 will go. And similarly, likewise, in every half-life, the 50% of the remaining is going to go when single dose is being given. So that's the one relevance, when the drug would get almost completely eliminated from the body. Half-life is also important for understanding when would the steady state level achieved. The concentration, when would it reach plateau, which means the absorption would be equivalent to elimination. Again, that also takes about 4 to 5 half-lives. So this helps us to understand how frequently the drug should be eliminated. So that's about the half-life. And in the next graph, I will also explain you different types of patterns and the eliminations, distribution half-life and the elimination half-life. So we have spoken about the minimum effective concentration here, which is the dotted line here. Now suppose I draw again another maybe horizontal line like this. I'm sorry, I think there is some problem in the marker. But if I draw a horizontal line which is parallel to this level, and I call this as the maximum tolerable concentration. So between this line and this line, I would have a range. This range is called as the therapeutic window. So therapeutic window is basically nothing but the range between the maximum tolerable concentration and the minimum effective concentration. That's the therapeutic window. Now there is a term called as therapeutic index. Now window is basically range between those two levels, and index basically is nothing but the ratio. So when you take the ratio of the toxic concentration to the tolerable concentration, you all have heard the LD50 by ED50. So that's the therapeutic index. So index, when we say, it's a ratio, and when we say therapeutic window, it's a range of concentration. So that's about this particular graph and the relevance of understanding this graph. Now coming to the next graph that I will show you. Just give me some, I think there's some issue. Okay, now there are two more graphs. You can see one graph here. This graph again is talking about the plasma concentration versus time. But now here you can see there is a distribution phase and then there is an elimination phase. So you can see there are two different types of patterns that are seen. Now this was the graph which was given by oral route when the drugs like A, B, C and are given orally, and this one is by intravenous administration. So when the drug is given intravenously, there is a alpha phase and there is a beta phase. So alpha is about the distribution and beta is about the elimination. Now those perpendicular lines and the horizontal lines will tell you that what is the elimination that is happening and what would be the half-life of the medicine. So from 2 to 1, how much time it is taking to reach from 2 to 1, that would be called as the half-life. Now the basic difference here, you can see the graph is going upwards here and the graph is going downwards here. I can calculate the area under curve for this graph also, and I can calculate the area under curve for this graph also. Now the concentration that has been given here is the normal concentration, which is not converted into log concentration. But if you see here, the concentration is converted into log scale. Now what is the reason for converting the graph for this one into log concentration and not for this one into log concentration? Because here you can see the concentrations are going down. So here the log concentration. So basically, when you convert the concentration into log concentration, two things we get an advantage. Number one advantage that we get is that the because the logs are smaller numbers compared to the normal numbers, we can accommodate multiple time points on the log paper. And second thing is when the log is taken, the line becomes straighter. So the calculations becomes easier. And that's why in pharmacology, you must have also seen in bioassays or in pharmacokinetics, multiple places we use this log scale. And we will be discussing about what is the relevance of this log scale and how do we calculate the log and anti-log, and then we make sense of this log anti-log into calculations. So that's about the second graph. The third graph here, you see there is a steady state concentration which has been spoken by Dr. Shambo also. So when you give the drug, the concentration goes up and the concentration goes down. Repeat the second dose, the concentration goes up, concentration goes down. Now, this will keep happening, but a stage will come when the concentration does not increase further because the rate of absorption becomes equal to rate of elimination, and this is called as the therapeutic concentration, which is a steady state concentration. Now, this is where we have to, again, what is the relevance of the steady state concentration for the pharmacology or maybe for clinicians? So typically when somebody does the therapeutic drug monitoring, when patient is not responding and the drug is on, so we might have to take the blood samples for doing the therapeutic drug monitoring. Now, generally, the samples are advised to be taken during the therapeutic drug, during the steady state. Once it is reached, then you can take the concentration. And for different drugs, there would be different kind of recommendations because for some drugs, it might be advised to take whole blood. For certain drug, it might be advised to take the plasma concentration. For example, when you give the immunosuppressants, generally like tacrolimus or the sirolimus, for those, generally the whole blood is advised. For many drugs, the plasma would be, I mean, the serum is advised or the plasma is taken. So when would you take is here when the patient is on the therapy and patient is not responding, the steady state concentration. We saw that in 4 to 5 half-lives, the steady state concentration is achieved. So those are the simple pharmacological concepts that we all are aware about. Now coming to the next discussion, which is about the distribution. Now I have drawn one graph here. I have drawn one table here, and then there is a diagram here. So I will talk about all three, and then we will go to the next one about the next concept. So the distribution, we all know the body water is about 60%. And of this, 25% is extracellular and 35% is intracellular. And the extracellular is further divided into the interstitial fluid, which is of 21%, and plasma, which is of 4%. So this is physiology. Now, what is important to us in terms of pharmacology? Because we might have different types of drugs, and broadly, you can see there are 4 categories of drugs that I have enlisted here. There are certain drugs which have very high plasma protein binding, or maybe they have very large molecular weight. Now, if you look at this category number 1 drug, they predominantly will remain here in the vasculature because they have a high plasma protein binding, so they will remain in the blood. And also, if they are having large molecular weight, so the category number drugs 1 would be almost the drugs which will remain here. If you want to calculate the volume of distribution for this category of drugs, the volume of distribution for this drug would be approximately, which is equal to plasma, which is nothing but 0.05 liters per kg. So category number 1. Then there would be certain drugs which are lipid insoluble. They would be restricted to the extracellular space, which is here in the 2. So the volume of distribution for this kind of drugs would be equal to extracellular fluid, which is about 0.2 liters per kg. Then there are some drugs which are lipid soluble. So they would leave the intravascular space and they go to lipid soluble, the lipid areas. So the category number 3 drugs which are lipid soluble, the volume of distribution for those drugs would be equal to total body water, which is about 0.65 liter per kg. And there are also drugs which are extensively tissue bound. They go to all the tissues. And the volume of distribution for those drugs is more than 1 liter per kg. And this concept is important for us to understand because for certain drugs, we recommend loading. Now, loading is required if the drug is extensively tissue bound and the site of action is somewhere else. So that's the relevance of understanding what is the distribution and what is the type of drug, where it would go, and what would be the relevance in terms of clinical practice. So having understood or maybe discussed some of the basic concepts of pharmacokinetics, now another concept in pharmacology is that there is a human body. Unfortunately, human body is very complex and there are several compartments. Like I showed you in the previous diagram, plasma, extracellular fluid, lipids, and then we have tissue. So there are so many compartments. And there is always a bilateral movement which is happening. From plasma, the drug is going somewhere else. There might be redistribution happening. From one compartment, the drug is going to other compartment. So when we want to do calculations of the pharmacokinetics for the compartmental model, and human body is a compartmental model, there are multiple compartments. So the compartmental modeling and non-compartmental modeling. So for calculation, softwares are required for calculating the compartmental modeling PK calculations. But when it's a non-compartmental modeling without any assumption, straight away the values are given and straight away you calculate them using formulas. That is what is the non-compartmental modeling. Generally for rapid drugs which are having rapid pharmacokinetics or linear pharmacokinetics, uh, they are calculated, or the pharmacokinetic is calculated for those drugs because they have a non-compartmental modeling. And generally we take the raw data which is been directly given to us, and then we calculate the PK parameters. But the compartmental modelings, because there are so many compartments and there are lots of assumptions that will need to be taken into consideration. So this compartmental modeling would be better for medicines or the drugs which undergo non-linear pharmacokinetics, or the drug which has very complex pharmacokinetics, or if you have multi-study data, then compartmental modeling would be useful. So by and large, we will be discussing about the non-compartmental modeling, because in the compartmental modeling, doing mathematical calculation manually would be difficult, and that's why generally softwares are commonly used for doing the compartmental modeling calculations. Now the next concept before we go to the calculations, I showed you one of the graphs previous slides, which was about the, on y-axis we had the plasma concentration curve, which was converted into log concentration, and on the x-axis we had the plasma concentration. I mean the time, sorry. So on the x-axis we had time, but on the y-axis we had the log concentration. Now whenever we have one axis which is showing log and the second axis is not showing log, the second axis is a linear axis. So in my previous scale, the x-axis was linear because that data was not converted into the log scale. Whereas y-axis, which was the plasma concentration, that was converted into log. If such graph is plotted, that is called a semi-plot graph, or semi-log plot, not semi-plot, it's semi-log. Why semi? Because only on one axis we are using log. If we use log on the both axis, x-axis as well as y-axis, then it will be called as a log-log plot. So generally we have the semi-log plots because the plasma concentration we convert into the log and the time we keep as it is on the linear axis. So semi-log plots, where are they useful? And log plots or the log plots, where are they useful? Semi-log plots are ideal for the drugs which have exponential data, or the decay or the elimination is happening in an exponential matter or exponential manner. For the complex, I don't know what this power law relationship is, but generally in pharmacology, we don't use the log plot generally. By and large, we use semi-log plot. So that's what the take-home message is, that we understand semi-log plot is nothing but the concentration which is taken or converted into log, and the time is kept as it is. I think in our school days and you were in 11th and 12th, we had used this log papers and the log tables. So although I will be using Excel sheet for doing calculation, but I will also show you the log table and how do we actually see log and anti-log using the log paper. Because in bioassay, there might be generally some examiners might ask you not to use calculator, not to use Excel sheet, but use the log table. So we'll talk about log table also. But for today's workshop, when I'm taking examples of pharmacokinetic calculation, I would be rather using Excel sheet because those calculations are pretty faster, because you can inbuild the formulas, and the calculations can be pretty faster. So this is what is the log table. I have taken this from the online source of NCRT book. So like you can see the reference here. Why I wanted to tell you, because there's a disclaimer not to republish this, and we are not republishing, we are using only for the discussion purpose. So log calculation, there's a table for the log calculation, and we also have the table for the anti-log calculation. Now for log calculation, you can see there are numbers from 10 and the numbers go up to 99. So 10 number starts here and the 99 number ends here. So there are some rows horizontal and there are some columns here, and from 0 to 9 there are columns, and again the second part of the table start, which also has 1 to 9 columns. So why this is made like this? Because when we want to calculate the log of certain things, we need to know which part of the log table has to be used. Should we use the first half, or should we use the second half? Should we use a row, or should we use the column? Now let me tell you about what is meaning of log table and how do we use this log table. Just for example, this is not the example of pharmacokinetics. This is general example of using the log table. So in the log table, there are two concepts. One is called as the characteristics and one is called as the mantissa. Suppose I have been asked to calculate the log of 372.4. So now I will use this log table to calculate the log of 374.4. So when I want to calculate it, the log has already been calculated, but I'll show you how to go and reach there. So there are two things, 2.5710. So the first part before decimal is called as the characteristics, and the second part after decimal is called as mantissa. So characteristics and mantissa, these are two things that we need to understand. Anything which is before decimal is characteristics, and after decimal is the mantissa. Now let's do the calculation and you'll understand how I reached to that number. So if I want to calculate the log of 372.4, what I need to do? So I have mentioned this into 4 steps. Step number 1 is calculate the number of digits before decimal. So this is decimal. And how many digits are there before decimal? There are 3 digits. Minus 1. So there are 3 digits and we minus 1. So it becomes 2. So the first step is calculating the number of digits before decimal and minusing 1 from them. Step number 2 is now we have to calculate the intersect of the first 2 digits. First 2 digits here are 37. 3 and 7, 37. So we go to 37 here. Here it is 37. So go to the intersect of first 2 digits and third digit in a column. So third digit here is 2. So I'll go to 37 and I go to 2. And I see what is the intersect here, and I will use this value as the step number 2. Now the step number 3 is find out the mean difference for the 4th number. This is the 4th number. So now I have the 4 here. For the same row, I need to go and find out what is the 4 and do an addition of this. That is what is the log of 372.4. So now let's do this. So log of 372.4. So the number of digits before decimal minus 1. So these are 3 digits. I'm minusing 1. It gives me 2. So obviously the log is going to start with 2 point because I'm minusing 1 from here. Now the calculation of the intersect of first 2 digits in the row, that is 37 here, and 2 here, which is in the column. So this intersect is 5705. So I have written this here, 5705. And we have to use the mean difference, which is the 4 here. So this is what is the 4 that I will add to this 2505, 2705. So that becomes 2.5710. So this is how the logs are calculated. Now just quick example, and then we'll go to anti-log. Another example. So now there are 2 numbers, 41, which means now log will start with 1 because I have to minus 1 from this 2 number. So it will start with 1. So number 1. Then I will go to the intersect of first 2 numbers. Now my first 2 numbers are 41. So I go to 41. And the second is 2. So I go here. And that value I got is 6149. And the mean difference is 5. So I'll add to this. So the log of 41 becomes, or 41.250 becomes 1.6154. So we also should know how to use log table, and also we should use the Excel sheets. Now coming to the calculation of anti-log. Now this is the anti-log table. The previous one, this was the log, and this is the anti-log. So again, there are 2 tables here. Again, they start from 0 and they end with 99. Again, there are columns starting from 0 to 9, and again there are columns 1 to 9. So now suppose I want to calculate the anti-log of 4.1862. So what do? Find the number of digits before the decimal. What is the number of digits? Is 4. I have to add 1 to this. Now that becomes 5. So I'm doing an anti-log calculation. Again, there are 5 steps which I mentioned here. Again, we will calculate the intersect of first 2 digits, but after the digit in a row and third digit in a column. So I'll show you how to calculate this. Then we again go to the mean difference and we add the mean difference. Suppose now I have to calculate the anti-log of 4.1862. So the number is 4. This number is 4. So I'm adding 1, that becomes 5. So that goes to 10 raised to 5. Now the intersect of first two digits, the 18 and the 6. So this intersect is 1535 and the mean difference is 1. So I'll add that becomes 1536. So the anti-log of 4.16 or 4.1862 becomes 0.1536 into 10 raised to 5. Why 10 raised to 5? Because this is 4. We add 1 and that becomes 10 raised to 5 because the log, there are two types of log. One is called as a natural log and one is called as a common log. Now when I say common log, the base is 10. So this is called as the common log. The base is 10 and that's why we used 10 raised to 5. This is 4 and we converted that into 10 raised to 5. So this is how we use the log table and anti-log table for calculation. So again, we are not reached to the concepts of pharmacology. We just have discussed what is the pharmacology in nutshell, and then we discuss how to use log table. Now, I just spoke in the previous slide. There are two types of logs. One is called as the natural log here, and the other is called as the common log. Now remember, the natural log would be generally written as ln. N is natural, the log is L. So something written as Ln, that means it's a natural log. And which is not written, you consider this as a common log, which is generally log 10. So natural log, this one Ln, it uses the mathematical constant called as 2.718 as a base. So remember this number. So the base of Ln is 2.718, whereas the base of the common log is 10. That's a basic difference because we might have to convert one log into another. For example, converting natural log to common log and vice versa. Then we should understand what is the base of the natural log and what is the base of the common log. Now, if I want to convert the natural log into common log, the multiplication factor is the 2.303. So two numbers we have to remember. One is the base and one is the conversion factor. So base for the natural log is 2.7 and conversion factor for natural log to common log is 2.303. So this is again a concept because this concept would be required when we do calculations. The next concept is I showed you in the previous graphs when we had the pictures of those graphs. Somewhere it was plotted as a plasma concentration versus time and somewhere it was calculated as a log concentration. So to remember this, there is a phrase which is very commonly used in the literature, which is called as the linear up, log down. The method is called as the linear up, log down. It mentions that which method out of these two, plasma concentration versus time or log concentration versus time, should be chosen. Now they say that when the concentrations are rising, so for example, I showed you the graph where when oral drug was given, the concentration was going up. And when the IV was given, the concentration was going down. When the concentrations were going up, they say use the linear trapezoidal method. That means this one, linear up. Why linear up? When the concentrations are going up, that's the absorption phase. The graph should be plotted with a linear up. Whereas when the concentrations are going down, if you can correlate with the figure of the distribution and elimination half that I showed you in the right upper corner, that was the IV and the concentrations were falling. That is where they had used the log concentration. So log down, that means that method is used when the concentrations are going down. So this concept again becomes important because when you plot the graph, you should know, are you plotting the natural log versus time or common log versus time? Or are you plotting only concentration versus time? So this is another concept that we should be knowing. Now, when we look at this picture now, so there is a linear trapezoidal and the real curve. Now, if inappropriate method is used, there could be error in the calculation of area under curve. That is where we have to understand linear up and log down because the real curve is here, the blue one, and if you use the linear down, then there is a problem here. Now, looking at the formula for AUC, just remember the the formula for AUC at this point of time, but I will be discussing about how do we arrive at this formula for calculating the area under curve. So area under curve is calculated as C1 plus C2, that is concentration at time 1 plus concentration at time 2 divided by 2 into T2 minus T1. T2 is the time, second point and the first point. So for example, if we want to calculate the area under curve, I plot a line from 16 here and a line here. So that becomes a trapezoid. So the area under curve, for example, only between 16 and 17, I want to calculate the area under curve. Then I have to look at what is the concentration of 16 and what is the concentration of 17 and half of it. So C1 plus C2 divided by 2 and T2 minus T1. Now T2 becomes 17 and T1 becomes 16. So this becomes 1. So this is the formula for trapezoidal area, which is linear one. Whereas when you use logarithmic trapezoidal method, the formula is different, but this is the non-compartmental and this is also non-compartmental. So when you talk about the non-compartmental analysis, so we will be largely using this analysis when we will be doing some examples. We will be using area under curve calculation with the non-compartmental method, because I told you that non-compartmental is easy to calculate. And when we convert that into logarithmic, then the formula is different. C1 minus C2 divided by natural log of C1 minus natural log of C2 into T2 minus T1. So at this point of time, even if you remember one formula, this one is good enough because we'll be using that formula. And for other formulas, the softwares might be useful. So we'll be doing some exercises. The last concept before we go to the agenda number 3 and calculating actual slope and intercept and the PK parameters. The concept, we already have discussed about this concept. But why it is important to understand is that some drugs, they follow zero order kinetics and some drugs, they follow first order kinetics. Now, before we go to difference between first order and zero order kinetics, the next slide. This I have already explained you that about 4 to 5 half-lives are required for the drug to get almost completely eliminated. So after 5 half-lives, almost 90%, 97% drug has been eliminated and only 3% drug is approximately remaining in the body. So that concept is very well known. Now, most of the drugs, they follow first order kinetics. Very few drugs, they follow zero order kinetics, but we need to understand the difference between the elimination pattern between the first order kinetic and zero order kinetics. So as the name or the definition suggests that for the first order kinetics, fixed fraction of the drug is eliminated per unit time. Fixed fraction. Just for example, I have explained here in the left hand side. If the initial concentration was 100 microgram per deciliter, in 1 unit time it has become 50. That means 50% drug is eliminated. And if this 50% is the fraction that is being used by the drug, for all the time points or the unique time points, 50% drug will be eliminated. For easy calculation, I have taken this as a 50%. For every drug, it may not be 50%. But fixed fraction, some amount of fraction is fixed and that will get eliminated per unit time. What happens in the zero order kinetics is, instead of the fraction, it's the amount. So fixed amount gets eliminated. 100 becomes 90, 90 becomes 80, 80 becomes 70. So every unit time, fixed amount of the drug is getting eliminated. Now, the fraction and amount makes a lot of difference. The reason is that if you look at the elimination which is happening, rate of elimination, more is the concentration, more is the elimination. But here, the plasma concentration is not related, or rate of elimination is not dependent on the plasma concentration, because fixed amount is getting eliminated. Both clearance as well as half-life, they remain fixed here. So you can see for 100 to become 50 or 50 to become 25, the time taken is same. But suppose I look at here, the amount of time that is taken to convert 100 to 50 versus 90 to 45 would be different. So the time which is taken to decrease the half-life or the concentration to 50% is not fixed. So generally the half-life becomes irrelevant when the drug follows the zero order kinetics. We all know certain drugs, they follow zero order kinetics and those drugs are more toxic in nature. You can see here, some drugs, they follow the first order kinetic, but when the saturation happens, they become the toxic compound. Whereas in the first order, the fixed fraction of the drug is getting eliminated per unit time. Now, that was all about the concepts that we wanted to discuss in the pharmacokinetics. Now the actual calculations. So two concepts before we go to calculation. One is called as the slope and the other is called as the intercept. Now I told you that today we are going to discuss not just pharmacology but also the statistics and the mathematics and also the Excel sheet. Now slope and intercept, this concept is there also in the statistics. If you see the formula for calculating regression, so formula for calculating regression, it also uses the same slope and intercept concept. So let's talk about what is slope and what is intercept. Now here on the y-axis, natural log has been given. Natural log plasma concentration in microgram per ml. So from 0 to up to 7. So this is the concentration. And on the y-axis, we have the time. So this becomes a semi-log plot because this is a log and this is the linear number. So semi-log plot. Now what is happening here is, suppose I would not have calculated the concentration at 0. I would have started finding out the concentration because at this point of time drug was given. Then I started calculating concentration from here for an example. So I know what is the concentration at time 2. I know what is concentration at time 4. I know what is concentration at time 6, 8, and then I plot a graph. But I do not know what was the concentration at time 0. And I also don't know what is the rate at which the concentration is decreasing. And I also don't know when this concentration would touch the 0 value or the baseline value. Now the intercept, the name tells you what intercept is. Intercept basically means it is intersecting. This particular best fit line is intersecting with the y-axis. So this is called as the intercept. But when you look at the elimination, it's an exponential elimination. Now, there is a fixed amount, some amount is getting eliminated, but there is one constant which is called as the elimination rate constant. So slope is nothing but the elimination rate constant, which is called as the K. Some books say KEL. Some say elimination rate constant. And remember, this value will always be negative. The reason why this value is negative is because it's decreasing. So slope would be always in negative number. Now what is slope? Basically is nothing but the calculation that we have to do for calculating slope. For intercept, layman definition would be where is it intersecting. But if it is given in the plain plasma concentration, then it is easy to say that this is the intercept. But when it is given in the log concentration, then we have to convert that into the linear number. And that is where we have to use log tables. How do we calculate slope? Slope is calculated as the formula y2 minus y1 divided by x2 minus x1. So remember this formula. Y2 minus y1 divided by x2 minus x1. What is y2? Suppose this is y1. This is y1 and this is y2. So this, the difference between these two is called as y2 because this is on y-axis. Divided by x2 minus x1. This is x1 and this is x2. 6 minus 4. That becomes 2. So use two values on the y-axis and get a subtraction of this divided by the subtraction of two consecutive points on the x-axis. So simple to remember formula is y2 minus y1 divided by x2 minus x1. That gives you slope. So that was about the intercept and slope. So slope is nothing but the elimination rate constant and it is calculated by the formula y2 minus y1 divided by x2 minus x1. And intercept is nothing but the best fit line of regression. The best fit line is this line because there are different data points, but the graph will use the best fit having equal distances or at least some kind of mathematical assumption and the best fit line from all those data points which intersect the y-axis. That is called as the intercept. So you all would have heard the formula called as y is equal to mx plus b. So what is y? That you want to calculate y is equal to mx plus b. So now there are two things, mx and b. So one of them is slope and one of them is intercept. When I show you the formula, you will be able to understand what is the meaning of y is equal to mx plus b. Now the agenda number 4, because here again the agenda is to understand the simple mathematics. how the log is converted into natural log is converted into common log, and how do we convert the common log back into the anti-log. That is what is called as the basic math, and then we will be doing the exercises. I think I already spoke about the difference between common log and natural log. I will just show you some of the examples when to convert and how to convert them. For example, here, log to the base 10, x is equal to y. So the base here is 10. Whereas for the natural log, the base would be 2.7. So now look at the natural log. The base e, this is the 2.718. The e, which is the base, is called as the Euler's number. The Euler was probably a scientist who gave this number. But what is important for us? If something is given here, I want to calculate the value of x. So x is equal to 10 raised to y because the base is 10. So if I want to, what is the calculation or what is the value of x? It would be, you have to take this 10 on this side, 10 raised to y. Similarly, if I want to calculate the value of x here, but this is natural log, then I have to use e to the power z. I have to take this e here. Now e, I told you, is nothing but a Euler number, and Euler number is nothing but the 2.718. So Euler's number is 2.718. So again, just to revise the concept, natural log uses base as 10, and a common log uses base as a 10, and natural log uses base as e. E is nothing but the Euler number. So that is what is the basic mathematics. So natural log of e is equal to 1. And we all know that natural log of 10 is equal to 1. Because here, if you look at this concept and you put this 10 is equal to, or x is equal to 10. So for example, here we are calculating value of 10. So 10 is equal to 10 raised to 1. So 10 is equal to 10 raised to 1 because this is 10 and 10 raised to 1. So that is why the log of common log of 10 would be equal to 1. Whereas the natural log of e is equal to 1. Now if I want to convert this, then I have to use some conversion factor. And I told you that conversion factor is 2.303. So if I want to convert natural log into common log, I have to multiply by 2.303. And if I want to convert the common log into natural log, then I have to divide natural log by 2.303. So two numbers to remember. One is the base and one is the conversion factor. So natural log of 10 is 2.303. And that is where we have to use that as a conversion factor. So you can, now for example, log to the base 10, 100 is equal to 2. So now I know that natural log of 100, I have to use multiplication factor 2.303 because it's a multiplication factor. So I'm converting this into the natural log. So natural log of 100 will become 4.606. The common log of 100 was 2, but the natural log of 100 has become 4.606 because we use the conversion factor. So this is the mathematics, simple mathematics. Now if I want to take an anti-log of x, then obviously x raised to x, 10 raised to x, because this 10 will go this side and that will become 10 raised to x. So these are the simple mathematical calculations. Now let's do some calculation because concepts, we already have spoken multiple concepts. Hopefully those concepts now are understood. Now we'll do some calculation. So I was telling you about the one compartment model, zero compartment model, no compartment model, non-compartmental or multi-compartmental. Now suppose there's only one compartment. That means from one compartment, the elimination is happening at certain rate. This is the elimination rate constant. The E is Euler number and this is the elimination rate constant. And assuming that this is a single compartment, only one elimination rate constant is here. Now suppose I want to calculate the concentration at time C. For example, concentration at this point of time. What is concentration C? For which I need to know what was the concentration at baseline. What was C0? So if I want to calculate concentration here, I need to know what was the concentration here. And I also need to know what is the elimination rate constant. At what rate and at what fraction, constant fraction it was getting eliminated. because this is the exponential decay. Now, exponential decay concept has come from the radioactive isotope, because when radioactive isotope research was done, they wanted to understand at what point of time the radioactive isotope will remain 50% of its original value, because the radioactive isotope follows exponential kinetics, and from there the concept of half-life would have emerged. Now, why it is important to know that we need to calculate C0? Because the elimination or the concentration at different points will depend upon what was the concentration at C0. So this is called as C0. So the concentration at any point of time is equal to, following the first or the single compartment model, C0 into e raised to minus kt. Now let's look at, if I convert into log, because here they have given natural log. So now I have to convert into natural log. So I put the natural log of C is equal to natural log of C0 into e raised to minus kt. E is Euler's number, kt is the elimination rate constant. Now, this is the concept. When there are two numbers in the bracket, we have to separate them out. We have to separate them out. The formula or the concept, when there are two numbers here, then we take separately natural log of first number plus natural log of second number. So we use that concept here now. So now if I want to calculate the natural log of C, I will take the natural log of C0, and the natural log of E I know is 1. So that is gone now. Natural log of E is 1. So only kt remains. So this is the formula for calculating the concentration at any point of time. Now the conversion factor, because here we have used natural log. Now we want to convert the common log. So conversion factor is 2.303. We spoke about that. So this is converted into common log by multiplying 2.303 is equal to, now I am multiplying everywhere. So when I divide it, it becomes log C is equal to log 0 minus elimination rate constant divided by 2.303. This was for the natural log. This is for the common log. So these are the calculation. So if the graph is given in the form of a common log and not the natural log, the slope here, the slope would be calculated as elimination rate constant, which is kt, or the slope is equal to kt divided by 2.303. So this formula we have to remember. kt is elimination rate constant divided by 2.303. So carefully look at what is given on the y-axis, whether it's a plain plasma concentration, whether it's a log concentration, or whether it's a natural log concentration. Now this formula is for the natural log. This formula is for the this formula is for the common log. This formula is for the natural log. And when the plain concentration is given, then you don't have to do any logarithmic calculations. So intercept, now if you go back and trace it here, the intercept would be log of C0, because this will be converted into common log. So intercept would be directly log of C0. So I have converted this into the common log. At this point of time, it is given in the natural log. So it's up to us to convert and look at very carefully what is given on the y-axis. So anti-log calculation, I was telling you the y is equal to mx plus b. You can see here the y is equal to a plus bx. Now there are two numbers here, a and bx. A is nothing but the intercept and b is nothing but the slope. So I can calculate the value of y if I know the value of x, because I can calculate the slope and I can calculate the intercept. So this is slope and this is intercept. Now the next concept, which is the agenda number 5, and these formulas are straight away copied from the books, but we will also have understanding how did this formula arrive, what was the origin of this formula. So some formulas we have to remember. VD, volume of distribution, is equal to dose divided by C0. Now we know what is C0. C0 is the plasma concentration at time 0, which is nothing but the intercept. So volume of distribution, when we discuss the general concepts of volume of distribution, we spoke about what is the importance, because volume of distribution, it can help to decide whether loading dose would be needed or not needed. And generally, when the volume of distribution is very high, loading dose is required. But how do we calculate volume of distribution? The dose divided by concentration at C0. So this is formula which we all are aware about. The second formula which I spoke when I discussed the slope and intercept, the slope is nothing but the y2 minus y1 divided by x2 minus x1. So this is what is the formula for slope. Half-life is equal to 0.693 divided by elimination rate constant. And for those who are interested to understand from where this 0.693 has come, this is the natural log of 2. Natural log of 2 is 0.693 divided by Ke. And we calculated Ke by different numbers or different formulas. So half-life is calculated as natural log of 2 divided by the Ke. Why natural log of 2? I told you the concept that the radioactive isotope, the concept has emerged from there, and they wanted to know when would be the half concentration achieved. And that is where they took the natural log of 2. Now, the Ke, elimination rate constant, can be calculated as the formula Cl divided by Vd. Cl is clearance. If I put this formula here, in place of Ke, I put Cl. So what happens here is the Cl will remain, but the Vd will go up. So the formula will convert into half-life is equal to 0.693 into Vd divided by Cl. So which means I can calculate half-life only when I can know what is the elimination rate constant. If Cl and Vd is also given, I can calculate half-life because Ke is nothing but Cl by Vd. So the half-life can be calculated by another formula. The Ke can be calculated. For example, here you want to calculate Ke, elimination rate constant. It's simple. Ke is equal to, you take Ke this side and you take half-life this side. So Ke is equal to 0.693 divided by half-life. 0.693 is the natural log of 2. So half-life, look at this number now, the formula number 3, half-life. So half-life is calculated as 0.693. Instead of Ke, we place Cl by Vd. So the Vd goes up, Cl goes down. So half-life is equal to 0.693 into Vd divided by Cl. The last formula is loading dose is equal to volume of distribution into plasma concentration. Now, volume of distribution can be calculated by this formula. So if you know the plasma concentration and volume of distribution, you can know what would be the loading dose. Maintenance dose is equal to Cl, which is clearance, into plasma concentration. So the loading dose depends upon the volume of distribution and maintenance dose depends upon the clearance. The plasma concentration here is nothing but the steady state plasma concentration or therapeutic concentration. So how much is the therapeutic concentration that you would need into volume of distribution? That gives the loading dose, and maintenance dose is equal to Cl into plasma concentration. Cl is nothing but clearance. Now coming to few more formulas, and this is my last slide of the formulas. Then we actually will go into demonstration and the calculations. Area under curve. Now I showed you one of the graphs and we could plot multiple trapezoids in that graph. Because for every time point, I can plot a vertical line. So I have multiple trapezoids. So from trapezoid 1 to trapezoid last, if I want to calculate the area under curve, all of those trapezoids, then I would calculate area under curve from 0 to time, which means up to what time the concentration has been taken. But we know that the line was not touching 0. We do not know when that line will touch 0, and that is where it is called as infinity. So from 0 to t, I can calculate straight away. But for t to infinity, the last one, the last trapezoid which is touching the baseline, I need to calculate it separately. So area under curve total 0 to infinity is equal to area under curve from point 0 to point T. That means up to what time the concentration has been taken, up to what time the blood has been taken or the plasma has been taken, plus the last trapezoid, area under curve T to infinity. I will demonstrate this and then it will become little more clearer. Now these three formulas, they might be useful for the clinical application. Hopefully, after my sessions, when there are clinical sessions, this formula might be more relevant. So creatinine clearance, we all know, is calculated by the formula. It's a formula called as Cockcroft-Gault formula, and it's the international standard accepted formula. The creatinine clearance is equal to 140 minus age in years into body weight in kg divided by 72 into creatinine in milligram per deciliter. So creatinine clearance, we need to know what is the creatinine. So from the creatinine, the body weight and the age, we can calculate the creatinine clearance. And in females, the multiplication factor 0.85 is used. Now for certain weight, certain calculations of the drugs, we might need to calculate the different weights, because whatever is my body weight is actual body weight. But sometimes that actual body weight may be not the ideal body weight. So we have to calculate ideal body weights in some patients. Now in some patients, the adjusted body weight. So adjusted body weight is calculated as ideal body weight plus 0.4 into actual body weight minus ideal body weight, which means I need to know what is the ideal body weight. So the ideal body weight for male and female, it is given by the formula Devine formula. There are multiple formulas, but Devine formula is commonly used. So Devine formula says that the ideal body weight for male is equal to 50 kg plus 2.3 kg per inch for those people who are over 5 feet. And for female, the base is 45.5 and the remaining is same, 2.3 kg per inch over 5 feet. But these last three formulas I'm not going to use for the basic calculations of the pharmacokinetics today. Now, when do we use adjusted body weight? That is required for patients who have a more than 120% of the ideal body weight. For only those patients, adjusted body weight is recommended. I have spoken about the one compartment model. So one compartment model, when we look at this formula, C is equal to C0 e raised to minus kt. Log of C is equal to, we have put the logs everywhere. And this formula, log C is equal to log of C0 minus K divided by 2.303 T. So I was telling you that for those who are interested in understanding from where this 0.693 has come, so this is the calculation for those people. Those who don't want to go into details, for them just remember half-life is calculated as natural log of 2 divided by K. So natural log of 2 is 0.693 and divided by K. And these are the previous steps. How did this formula arrive? And the mathematical calculation. Again, this would be too much for, and that will add further confusion to what we have discussed. So we will not go into that detail, but remember half-life is equal to 0.693 divided by K. Now, the two agendas, first one is the calculation of the AUC and then the calculation of other PK parameters. So AUC is nothing but area under curve. And the area under curve can be calculated by multiple methods. At least 4 of them I will be discussing here. And very briefly, one method in detail, because mathematical method we will explain in detail. But remaining 3 methods, these 3 methods, they're not very commonly used, but we should know that there are other methods also. So the method for area under curve calculation, either I can use planimeter, we can use cut and weigh method, counting square method, and I'm going to explain this method called as the trapezoidal rule or the trapezoidal area calculation, which is a mathematical method. Of course, other also use mathematics. Planimeter is an instrument. It's a hardcore instrument which is used for calculating the area under curve for the areas which are irregular. Like for square, for triangle, we know the simple formulas can be useful and we can straight away calculate the area by using those formulas. But for Areas where the sizes of the sides are not equal, for them planimeter might be useful. So this is one method. The second method is cut and weigh. Now what do we cut and what do we weigh? Basically this method is used for cutting and weighing the graph paper. You can see there is a graph paper here. So the graph paper, now I take a complete one blank graph paper and I weigh that graph paper. The first graph, the complete graph, I weigh, and I will use the symbol to mention the weight as W1. So W1 is the weight of the whole graph paper. Now what I do, I plot the area under curve. This is the area under curve. Now those areas where there are no points plotted, I will cut them. And I will only take out the area under curve. So I'm cutting it. So what is cutting? What is cut? The plotted area under curve is cut. Now I will weigh this particular cut part and I will measure this as W2. So I have a W1 which is the whole paper and W2 which is the cut area of the area under curve. Now the formula for calculating the area under curve using the cut and weigh method is I am calculating the area under curve of 2, which is this area. But I knew what is the area under curve of the first one because I had the squares, I had the length, I had the width. So I can calculate the area of that whole paper before I actually draw the area under curve, the whole paper. So that is area under curve 1 into the weight of this paper and divide by weight of the whole paper. But again, this is a very crude method. In today's evolved era and where we have sophisticated instruments, I don't think anybody uses the cut and weigh method for calculating the area under curve. But there were days where when the science was not evolved that much, maybe this method was useful. The third method was the counting square method. So after this was the counting square. Now what is counting square? Basically, you have the graph and you just count the squares in this area under curve. How many squares are here? And those who have handled the graph paper, they know there's a one big area, and when you zoom it, again there are multiple small areas here. Why it is important to know that there are multiple smaller areas inside this large square is because some areas when we cut, they are cut into different portions. And that is where we have to look at the smaller squares and we know how to calculate the area of square. So you just calculate the number of squares and take the area of each square, sum it up. That would be called as the third method, which is the counting square method. So we have planimeter, we have cut and weigh method, we have counting square method, and the last one is the trapezoidal area method or trapezoidal rule method, which I will explain you now. So let's talk about the trapezoidal area method. Now from where this trapezoidal rule or trapezoidal area method has come? This has come from the area of trapezoid, because those areas when we plotted the perpendicular lines from the concentration to the time, those areas they look like trapezoids, and that is where the trapezoidal area rule is used for the calculation of AUs. Forget about the pharmacokinetics. If a mathematician was to calculate the area of this trapezoid, he would have used this formula called as A plus B divided by 2 into H. So A is here, B is here, the length of both this trapezoid, two lengths, into height. Height is this one, from distance from A to B, it is divided by 2. So A plus B divided by 2 into the height. Now we also have similar structure when we calculate the area under curve. So we use the same formula. But the problem with us is that we have multiple trapezoids. And typically we can use this same formula for all trapezoids except two trapezoids. The first trapezoid and the last trapezoid. which means if I want to calculate the area under curve, I have to calculate the area under curve by trapezoidal rule for all the traditional and complete trapezoid by using this formula. But the two trapezoids are not complete, the first one and the last one, which means for that I have to use another formula. So which means for calculating area under curve using the trapezoidal rule, I need to know three formulas for calculating area under curve. So now let's look at the area under curve calculation. This is a dummy example that I have plotted. So total area under curve is equal to sum of all area under curves of all the trapezoids. Now when you look at this particular graph very carefully, on the x-axis you can see hours, on the y-axis you can see direct, the linear plasma concentration, not converted into log, plasma concentration in microgram per ml. The concentration was started to calculate from time 1 hour, not at 0. Time 1 hour, the concentration was C1. At time hour 2, it was 2, and likewise from C1 to C6. Now those numbers that I have written here, 1, 2, 3, 4, 5. So for 5 trapezoids, I can easily calculate the area under curve by that formula C1 plus C2 divided by 2 into the height. But I also have the trapezoid here, which is not complete. Had I taken the concentration at time 0 here, then I would have one complete trapezoid, but the concentration was not measured. So which means now I have to estimate the concentration which would be here. And that is where I draw a backward line which will touch the y-axis. This would be called as C0. So now I have another trapezoid here. Now this from C6, I do not know when it will go down. And then I would have another trapezoid here. So I would have 7 trapezoids. 1, 2, 3, 4, 5. These 5 are traditional complete trapezoids. And 2 trapezoids, number 1 and number 6. Sorry, number 0, not 1. Number 0 and number 6. These are incomplete trapezoids. So what I do for calculation of the complete area under curve, so which is called as 0 to infinity, because I don't know when this 6 is going to come to down 0, infinity. So area under curve 0 to infinity is equal to area under curve of 0 to 1. That means from here to here. But I don't know what is the line here. So I have to plot a line backwards. So this becomes AUC 0 to 1, AUC 1 to 2 from here to here, 2 to 3, 3 to 4, 4 to 5, 5 to 6, but from 6 to infinity. So the last one would be from 6 to infinity. So that's how I started from 0 and I'm ending at infinity. So this is how the area under curve for 0 to infinity is calculated. Now let's calculate actually with a dummy example. So I draw a hypothetical line which is touching here. Now how do I plot this line? Should I plot it manually or should I plot it with some kind of scientific expertise? Obviously with scientific expertise, because manually the numbers might go wrong. So we'll see what is that method and how do I go backward to calculate C0. Similarly, when I plot here, this will go again here and another trapezoid becomes here. So this is what is the sum. Now the next thing is my demonstration part. Having understood all these concepts, we will be talking about the first of all demonstration, and then I will talk about how to calculate all those concepts that we have spoken since last almost 1 hour and 20 minutes. So I will first plot the graph, which is called as semi-log, which is the normal graph, not the semi-log also. Plasma concentration on the y-axis and time on the x-axis. Then I will talk about how to calculate log using Excel sheet and how to plot that graph converting log and then time on the x-axis, and those all calculations. So this is dummy example, hypothetical example. The question given here is 250 milligram of dose of any medicine XYZ medicine was given to the patient, and this was administered as an IV bolus. And the drug follows first order kinetics. We have discussed everything. First order kinetics, most drugs follow. And we have mentioned that when IV drug is given, the concentration goes down. That means we also have discussed linear up log down approach. So now the concentration is going down. So log approach would be appropriate because the concentration is going down. And the concentration that have been taken by the researcher at different time points, they have been mentioned in this table. We have been asked to calculate the PK parameters of this patient with the 250 milligram of dose given by IV bolus. So let's first talk about how to plot the graph and then how to calculate those numbers which are relevant. So first we'll talk about plotting the plasma time concentration curve. So I'll use Excel sheet, as I said, and then we will see how to use Excel sheet for even calculating the PK parameters. So the graph that I calculated, or the graph I plotted here, you can see this graph. And I'll show you how did I arrive at this equation also. But before we come to this equation, the graph, you can see at 0 point, there is no concentration, so I don't know what is the concentration. At time 1 hour, the concentration is 133. At time 2, the concentration is 117. At time 3 hours, concentration is 104. Concentration at 4 hours is 92. And you can correlate these numbers. So what I did was, I used Excel sheet and I used a trend line, which is called as the best fit line, trend line. And in Excel sheet, I asked that Excel sheet to give me equation also along with the trend line. And this equation has been given. I was telling you about the y is equal to mx plus b. So you can see here y is equal to mx plus b. So what is mx and what is b? So y is nothing but the concentration, because on y-axis we have concentration. On the x-axis we have the time points. I told you that the slope would always be minus. So this minus value has come as a slope. And the intercept is 141.87. Intercept means when you go backwards. So if I would go backward here, the line would touch the y-axis at 141.87. This is given automatically when I plot this particular graph in the Excel sheet. So I can get the regression equation using this particular function. So now let's go to the practical demonstration of how do we arrive at this number and how do we make sense of the graph. So what I did was, the same number that are given as an exercise to me, I wrote them in the Excel sheet here. And in the Excel sheet, I went to the tab called as Insert tab. From the Insert tab, I went to the scatter plot. And I asked the Excel sheet to draw the scatter plot. Obviously, the Excel sheet is going to ask which data should we use for scattering the plot. So we use this data for the scatteration. So you can see here, the Excel sheet has given me some plots, but we are not very nicely joined with each other. I need to use a line to join this. But before that, I know what this is. But for other people to understand, I need to label this chart. So what I would do is, first in the next step, I would label this. So in terms of labeling, so what I do is, I right click here, and on right click, this particular function opens up. There are so many functions here. The two functions which are very relevant to me is the labeling of the axis and labeling of the overall chart. Now what would I label on the y-axis? Because on my y-axis is the plasma concentration in microgram per ml. So I label this as a plasma concentration in microgram per ml. On my x-axis, there is a time point, and time is in hours. So I will write time in hours. And the chart title I would write as plasma concentration versus time curve. And that label has been done now. So plasma concentration versus time curve, plasma concentration in microgram per ml. time in hours. But again, I have not plotted the best fit line here and that equation that I showed you. So I go to the next step now. I ask Excel to show me the line which joins in a best way to all these time points. So for that, I ask the Excel sheet to give me trend line, add trend line. I'm right clicking it and asking the Excel sheet to give me trend line. So this trend line will be best fit line going through all these time points. So now the trend line has been given. But below here, below the trend line, there's another function, very beautiful function called as display the equation on the chart. So when I click this, the equation is displayed on the chart. So whatever we have discussed in terms of uh, the slope, the intercept, those concepts, once we know, Excel sheet will give you directly what is the slope and what is the intercept. Now, having got that, that was the linear plasma concentration versus time curve. Now we have to calculate the, or maybe plot the another graph. So now I'm going to convert that the linear concentration into log concentration. So I'm going to plot log concentration on the y-axis and time on the x-axis. Only thing now I have to add one step. Whatever I did in the previous exercise, I will do the same thing in this exercise. But before going for the next step, the plane concentration I would convert into log concentration. Now you have two options. Either you use the log table or you use the Excel sheet. The Excel sheet gives you very quick, because log table you have to go and look out those numbers, but Excel sheet has a beautiful function to convert log. So what I did was, this table which was given to me, the first two rows were given already. I have added third column. And this third column is about converting plasma concentration into log concentration. Now, when I have mentioned is the log concentration, it means that it is a common log. It is not the natural log. Because had it been the natural log, it would have been ln. But when it is written as log, that means it's a common log. So how did I arrive at this number using Excel sheet? So what I did was, I wrote all these two columns in Excel sheet here. Our plasma concentration in microgram per ml. Now I don't have anything for our 0. So leave it. Now for the 133, 117, so column number 2, I need to convert that into log. So you all know that those who are aware about the Excel sheet works on a function equal to. Whatever calculation you want to do, write first equal to. So equal to log. Which log now? Log to the base 10. So this log I'm going to use. So this log I have used. So he will ask me which number you want to calculate the log 10 for. So then I will say, give me log 10 of 133. So log to the base 10, which is a common log of 133. When I put it, the value would be 2.1238 and so on and so forth. So for one number, when I calculate the log, Excel sheet has another beautiful function. You just drag down. So you don't have to do anything. You just drag down the functions. And when you drag down, you all have this log values automatically calculated with the same function that was here. Only the corresponding columns will be utilized by the Excel to calculate the log concentration. Now my second step is done. The conversion of the plasma concentration into log concentration. Now I have to draw a graph. And I will do the same method which I did in the previous exercise. So what I will do is, on the x-axis, I'm going to use the hours, and on the y-axis, I'm going to use the log concentration. I'm going to go to the Excel, and in the insert function, I'm going to insert the graph, which was the scattered plot. So I will go to insert now, and I went to insert, and again I will demonstrate you how did I go there. The formula, the slope, the intercept already is been displayed here. The trend line and the formula displayed on the graph. Now, when you want to make a sense of this particular equation, let's make a sense of this equation. Log concentration here at time number 1 was 2.1 something, 2 point some. If I want to go backwards, tracing backwards here, that would be called an intercept, where this best fit line will intercept. That intercept would be 2.1736. And you can make sense that, yes, possibly at 2.1736, this line is going to touch the y-axis. So this is called as the intercept. Now, intercept is nothing but the concentration at time point 0. But now this concentration is given in the log form. If I want to calculate actual concentration, which is the linear concentration or the traditional number concentration, I would have to convert this number, which is 2.1736 into anti-log. And that will give me the actual concentration because this is a log. The slope here, I have told you that slope would always be negative. So negative 0.052 into x. So x is basically the time and this is the elimination rate constant. So this is the equation. Let's now, like previous example which I plotted, I will plot this example also. Now I don't want to use the plasma concentration. I wanted to use the log concentration. So I went to Excel sheet. I went to insert. From the insert, I went to scatter plot. And from the scatter plot, I selected the first scatter plot, this plot. And once I selected this scatter plot, I asked the Excel to plot this versus this. You can see those gray color selection because the middle one is white. That means it is not selected. So selection is A versus C. And when I put A versus C for scattering, the scattering is here. And then I go to right side and ask Excel sheet to give me option for editing the chart. So title also is edited with the title and the x-axis and the y-axis. You can see here I already labeled them. On the x-axis I have labeled it as hours, and on the y-axis I have labeled now it as a log concentration because this is a log concentration. And when I am not putting anything, that means it's a common log to the base 10. And then next step I would ask the Excel sheet to plot a graph and along with a trend line. And along with the trend line, I will also ask the Excel sheet to give me the equation to be displayed on the chart. So trend line has been added and I have plotted here, display the equation on the chart. So this is the equation on the chart. This is the same equation that I plotted before. So this is how the basic and the first step, whenever you have been given the concentration versus time, you can plot the graph. Similarly, in bioassay also, we do DRCs. DRC stand for the response curve, drug concentration response curve. So you can beautifully use Excel sheet for plotting the DRC also. So for pharmacokinetics, those who are not doing any complex calculation, Excel sheet is good enough. Now coming to the calculation by using the formulas, those all calculation that we did, right from the calculation of the volume of distribution, the half-life, then the elimination rate constant, also the area under curve. So now we'll do all those calculations. So these are the calculations that I would be demonstrating. Slope. Now the slope and intercept we calculated using Excel sheet direct function which was there on the trend line. But mathematically, can I calculate it using some formulas? That we will discuss in this section. Then we will talk about C0, the intercept. If it is given in the log, if it is given in natural log, if it is given in the common log, how do we convert that? We're using Excel sheet. The elimination rate constant, volume of distribution, half-life, clearance, all those stuffs we will discuss in terms of calculating using Excel sheet. So let's do that. So calculating slope. Now just to revise, slope is basically nothing but the elimination rate constant. And the formula that we used was y2 minus y1 divided by x2 minus x1. So using this formula, we will calculate the slope. So now here, this was the same example, same Excel sheet. Y is equal to minus 0.05 to x. This is where the slope was. But if this is a slope which is coming directly on the trend line using the function of Excel, Excel also has another beautiful function where you don't have to do anything, just put the formula called as slope. So Excel will give you the slope automatically. But what is important for us is to understand what is meaning of slope. So if you don't know how to calculate using this trend line, you can use this function called as slope. So is equal to slope of what? Which two columns? Excel is asking you which two columns do you want to calculate the slope for? Because Excel would need the x-axis, Excel would need the y-axis also. So I'm asking him to give me the slope of this column versus this column. So now the slope has come as minus 0.05197 minus minus 0.5197. The intercept, the next step would be, will be calculating the intercept. Again, when you look at the intercept here, 2.1736. Excel has a beautiful function here. Again, is equal to intercept. Again, Excel sheet will ask, give me two columns for which you need to calculate the intercept. So I have given the column C3 to C8 and A3 to A8. The intercept is given as 2.1736. You can see here. So this number and this number is exactly same. The slope also was same. You can see the number here 0.5, 0.051, 0.052, because this 9 has been converted into 2. Now, whether you go with this approach of using the trend line and the best fit equation on the Excel sheet, you can directly use the formula is equal to slope and is equal to intercept. So having understood the elimination rate constant and the concentration at time 0, those are the two important parameters required for calculation of several other parameters. Because intercept is required for calculation of the area under curve. Slope is required for calculation of half-life. So that is where these two functions, they become important, and we can use them for calculating the other areas or other PK parameters. Now, having calculated the slope and intercept using two different methods, one method of using the Excel sheet with the direct function, and the other one using the trend line. Now we calculate the other PK parameters. So there are 4-5 parameters, or the 6 parameters here I have written. So 6 parameters. The first parameter is C0, which is concentration in microgram per ml. Then the elimination rate constant, volume of distribution in milliliters and liters, half-life, and then the clearance. The formula of the example here is different. The previous example we had used 250 milligram given IV, and the drug follows first order kinetics. Here, the drug follows first order kinetics, but the dose given is 1000 milligram. And for 1000 milligram dose, the concentration at different points, they have been allotted or they have been given to you. So this patient was given 1000 milligram. The researchers have calculated the plasma concentration at different time point from hour 1 to hour 6. And these are the concentrations. And these are log concentrations. So we have understood how to calculate the log concentration using Excel sheet. If not, you can use the log table. So having this calculated, now they are asking us to calculate C0, the all parameters. Now either you can use mathematical formulas that we discussed. you can draw those formulas in your notebook and you do mathematical calculation using calculator. That also is possible, but that's a little complex. If Excel sheet can give you those answers without putting too much of brain into it, then you can directly use Excel formulas. You can program and you can save that. You just have to change the numbers because the formulas can be used same over a period of time. So now let's calculate the PK parameters. Before we calculate, let's revise the formulas for these PK parameters here. And then on the third column, I would be showing you the result of these functions. So the C0 is nothing but the intercept. Now intercept, it can be calculated by three different ways. How? Just see what is given on the y-axis. If y-axis is a plain number and not log number, then whatever is the y-axis at C0, that becomes the direct number. But the conversion is required when the y-axis is in the form of a log. Now, if the common log is used, then we use 10 raised to intercept. If it is a natural log, then we use the 2.78 as a base. So, assuming that the concentrations are given in the log, we can convert that into 10 raised to intercept. If this was given as the natural log, I would have used here 2.7. The Ke is equal to slope into 2.303. Vd is equal to, we have seen, the dose divided by plasma concentration. But this is in ml. We have to calculate that into liters. So I am dividing this ml by 1000. That will give me results in the liter. The formula for half-life 0.693, which is nothing but the natural log of 2 divided by Ke, elimination rate constant. And the last one, which is clearance, is equal to Ke divided by Vd. Now, if all these formulas are given, then we will have to calculate what is there in the actual result. So we have already revised those formulas. Now we'll go one by one and calculate the C0 using the Excel formula. Okay, so now you can see here, the graph is given here. The x-axis 0 to 8, the y-axis log concentration, and the equation also has been given. Y is equal to this equation, mx plus b. Now I want to calculate using the formula 10 raised to intercept. Now if you look at this formula, there is one intercept and there is one slope. Intercept is 2.1736. This is the intercept. So I have written here the intercept is 2.1736 because I have to use that 10 raised to intercept. The slope here is 0.052. From where the slope has come? Slope has come here. From where this equation has come? This equation has come from this data. This data from where it has come? This has been given to us in the plasma concentration. We have converted that into log concentration. We have drawn the graph. We have taken the equation. Now that equation is useful for calculating here. So 10 raised to intercept. So I go to Excel here. You can see Excel. Intercept has been given here. C0 is equal to 10 raised to C10. What is C10? C and 10. This is intercept. C10 is intercept. So 10 raised to intercept. So 10 raised to intercept is nothing but the C0. 1.49. So if you can see here, it would be 1.49. Why? I am not calculating the log. I am directly calculating the plasma concentration because I have already used 10, which is the base, and to the raised to intercept, which means I am not calculating the log concentration. I am giving you the actual concentration. So C0 becomes 149.1305. So this is calculated. So again, just to revise, C0 is equal to 10 raised to C10, 10 raised to intercept. And intercept has been calculated using that Excel sheet, 2.17. So this is about calculating C0. Now calculating the KE. KE is nothing but the elimination rate constant. Elimination rate constant can be calculated by the formula here. Slope into 2.303. Now the slope is calculated here. We saw the slope is calculated here, 0.052. Now I will mathematically use the formula. So now I want to calculate the KE. So KE is equal to, the formula is slope is written here. Slope is written into C11. C and 11, the intercept. C and 11, this one. So this will be used for calculating the elimination rate constant because the formula is here, slope, into minus 2.303. So this multiplied by 2.303, the result will be here. So the result of KE is equal to 0.11961, 9691. So KE was, just to revise, KE is the elimination rate constant. The formula for calculating elimination rate constant is slope into minus 2.303. I'm calculating manually and with Excel sheet. With Excel sheet, I'm calculating here is equal to C19. I have written the slope in cell C19 multiplied by 2.303. The value is here. So this is what is the elimination rate constant. Now the next one, calculating the volume of distribution. So volume of distribution, the formula is written here. Dose divided by plasma concentration. Now, which is this concentration? Which is this concentration? So, dose divided by plasma concentration. So, I have written here C15. C15 is, C is here, 15 is here, dose. Because it is dose divided by plasma concentration. I have written dose here. So, dose is 1000. I am calculating into 1000 divided by C13. C13 is the dose divided by plasma concentration. So it comes as 6705.537. But this volume of distribution is given in the milliliters. Now I have to convert that into liters by dividing by 1000. So now when I use the same function and divide that by 1000, the volume of distribution comes as 6.705. This is extra, so this should be ignored. It becomes 6.705. So that is about the volume of distribution. The last two functions of the Excel to calculate the other pK parameters, and then we'll go to discussion on the calculation of area under curve and then bioequivalence. So calculating the half-life using Excel formula. The formula is natural log of 2 divided by KE. Natural log of 2 is 0.693 divided by KE. KE we have calculated already here. KE has been calculated. So I have written KE here, which is same function here. So this is written in the PowerPoint. This is written in the Excel sheet. So now I'm calculating the half-life, 0.693 divided by KE, C14, C and 14, this function. So the half-life will be calculated as 0.693 divided by 0.119691. So the half-life, now I would write whatever the result comes here, I will write it here. So the function, now the value is coming here, 5.79. So half-life is now 5.79 hours. The last calculation, especially for the Excel-based function, the clearance is equal to, the formula is here. Clearance is given as KE into VD. We already calculated KE here. And we also have calculated VD here. We just multiply this multiply by this. That becomes clearance. So now do that in Excel here. So CL by VD, uh, the clearance, the formula was, we discussed Ke into VD. Two things are written. Ke is here and VD is here. Use that formula of multiplication. So C14 Ke into, Excel uses star function as a multiplication, into C17, this one 6.70. So the clearance is 0.802589 liters per hour. So that function will come here. That result will come here. So now we calculated all the PK parameters. So for calculating PK parameters, what do we need? We need what was the dose given. We need at what time points, what concentration was achieved. If these three things are given, the dose is given, the hour points are given, and the plasma concentration is given, then we can calculate intercept, we can calculate slope, we can calculate C0, we can calculate elimination rate constant, volume of distribution, clearance, plasma half-life, everything can be calculated, provided we know what is the dose given, by which route it was given, at what time points plasma concentrations were taken out, and what plasma concentrations are seen. So that is about the different PK parameters. Now coming to the bioequivalence and the area under curve. So I'm left with the two different or two distinct functions that we will be discussing now. As I said in the beginning, that India is the capital of generics, and India exports a lot of generics to other parts of the world. And we have so many bioavailability and bioequivalence centers here. So if we don't know about how to look at the bioequivalence, and we being the pharmacologist, I think it's very important for us to understand the concept of bioequivalence. So the example we will discuss, and before that we will discuss the concept. So the concept here is we want to demonstrate bioequivalence between the test product versus the reference product. And obviously I have been using this Excel since last 1 hour and 1.5 hours. So we will be using Excel sheet only for calculating the bioequivalence between the test product and the reference product. Now, just to reiterate the definition which we defined in the very beginning of the session, bioequivalence is nothing but the comparative bioavailability of two products. So comparative bioavailability of the test versus the bioavailability of the reference. That is called as bioequivalence. But the test and reference product, they may not be 100% equal in terms of their bioavailability. So we have to go with the regulatory definition. What is the regulatory definition? We will discuss that. And we have to compare the bioavailability of the test versus the bioavailability of the reference. And we also defined in the beginning, bioavailability has two important regulatory definition point PK parameters. So two parameters are considered in the definition. Number one is the Cmax and number two is the AUC. So bioequivalence is calculated. So you calculated the AUC and Cmax of the test product. You calculated the AUC and Cmax of the reference product. Now what is what we're going to discuss. But in the bioequivalence, another important thing that we should remember is that generally in other statistics, we use arithmetic mean. But in bioequivalence, they use geometric mean. Now, why geometric mean is used? Because in bioequivalence, the data are log transformed. And whenever log transformed data are checked for normality, the normality is better for the log transformed data using the geometric mean. For the traditional data which is not log transformed, the normality is usually calculated by arithmetic mean and the standard deviation of arithmetic mean. But for the bioequivalence data, because the data are converted into logarithmic scale, And logarithmic scale normality is generally good with the geometric mean and the standard deviation. That's why the AUC and the Cmax that would be used in the bioequivalence calculation, it would be calculated based on the geometric mean and not the arithmetic mean. So geometric mean obviously would be lesser or maybe equal to arithmetic mean because it's a square root of the multiplication of A and B. That means the parameters that we the number of participants. So this is the formula for the geometric mean. This is the formula for the arithmetic mean. And because this is a square root, this is a division. Square root would be either equal or lower to this function. So this is one concept that you need to or we need to remember that geometric mean is commonly used for bioequivalence calculation. Now this definition is crucial and this definition has been taken from a reference of EMA, European Medical Agency, which is the highest regulatory body for the Europe. But the same definition is used by US FDA also. Same definition used by CDSCO, that is DCGI also. Now let's first dwell into the definition of bioequivalence and then we'll talk about how to calculate using Excel sheet. So this is exactly the wording copy pasted from the definition. For the demonstration of bioequivalence after a single dose, the parameters analyzed are AUC and Cmax. I have been telling this repeatedly. The Cmax and the AUC, rate and extent. These are the two things that we see in bioavailability and bioequivalence. Because there is an equivalence, so we look at two different things, product A and product B. Now the rate statement is crucial to understand the bioequivalence. For AUC and Cmax, 90% CI for the ratio of test and reference product should be within 80 to 125%. If this is the logic, and if this logic is accepted, or this fact is not logic, this is the fact. If this fact is accepted by the calculation, then we say bioequivalence is achieved. If this fact is not achieved by the calculation, then we say bioequivalence is not achieved. So again, once again, I will read the definition. For AUC and Cmax, 90% CI for the ratio of test and reference product should be within 80 to 125%. Now, having read this definition two times, what I'm supposed to do, number one, first I have to calculate the ratio. I have to calculate the ratio of test versus reference. Test versus reference of what? AUC. Suppose I have AUC of test, I have AUC of reference, I take a ratio of it. And of that ratio, I take 90% CI. And that result what I receive should be within the range of 80 to 125%. Same thing I do for Cmax. I have a Cmax of test, I have a Cmax of reference, I take the ratio of this two, then I calculate the 90% CI of this, and it should fall between 80 to 125%. If that happens, then we can say that two products are bioequivalent. And I will show you one example which is published in one of the literatures. After we understand our calculation and then we make sense of our calculation with the reference which is published and we see whether we understood bioequivalence or not. Before that, definition says 90% CI of the ratio of Cmax and AUC should be between 80 to 125%. Now, why range of 90% and why 80 to 125%? So, natural log of 8, 80%, 8, natural log of 0.8 is minus 0.2231 and so on and so forth. Because I told you that natural log is commonly used in the bioequivalence. What is the natural log of 0.8? 80% is 0.8, natural log is this. And also the natural log of 1.25, natural log of 1.25. This is also same, except there is a sign which is different, minus, this is plus. So both logs are exactly same. Only the difference is minus. And that's why this range has been taken 80 to 125%. So if the ratio 90% CI of the ratio falls in this range of 80% to 125%, the product is considered to be bioequivalent. Now, having understood the definition, generally we consider 95% CI. But for bioequivalence, the regulatory authorities are okay to go with the 90% CI. So now we spoke about why 90% because it's a regulatory definition. Why 80 to 125%? Because the natural log of 0.8 and 0.125 is same. So the range can be this. Now suppose I want to calculate the bioequivalence using Excel sheet, because the definition said that we first need to calculate the ratio of AUC as well as Cmax. We have to know what is the geometric mean, and then we have to calculate 90% CI, and then see whether that 90% CI falls within the range of 80 to 125%. Now let's go step by step. First is the calculating ratio of test and reference. You can see here, this is AUC, this is reference. This is about AUC of the test, AUC of the reference, Cmax of the test, Cmax of the reference. I have taken the ratio of all of this. Now once the ratio is taken, the 95% CI, 90% CI also has been taken, lower bound and the upper bound. And the definition says that the ratio, the 90% CI of the ratio should lie between 80 to 125%. So this is 80%, this is 121%. So this is within the range. So the ratio of the AUC or the ratio of the, 90% CI of the ratio of the test and reference product is within 80 to 125%. So this is bioequivalent. So for AUC it is good. What about Cmax? It should be for both, not just one. So we calculated the ratio, we taken the mean, then we calculated the 90% CI of the mean, and this also is within the range of 80 to 125%. This is what the product is bioequivalent. Now this is what I have done. So let's go step by step. How to calculate ratio, how to take geometric mean, how to go for the standard deviation, how to calculate margin of error, what is meaning of margin of error, and then we calculate the 90% CI. This is raw data. I will only demonstrate for the AUC. Same thing can be replicated for Cmax also. Now, suppose there are 18 volunteers and 18 volunteers have been given test product and the AUC is calculated like this for every individual from 1 to 18. Then whatever design, I don't know what design was used by the, because this is a dummy that I have created, but the design can be either parallel or the design can be crossover. Now whatever design was used, the AUC for reference is given here. Now for calculating the bioequivalence, I need to calculate the 90% CI of the ratio. That means first I have to calculate the ratio. The first thing I have to calculate is the ratio. Then I calculate the geometric mean, and then I will calculate the 90% CI. So ratio is been calculated. So either you calculate ratio of test to reference or reference to test. So generally test to reference. But even if you calculate reference to test, it should be between the same 80 to 125%. So this is now H19 divided by H39 divided by I39. So this divided by this into 100. The ratio is 104%. And then I drag down for all of the volunteers. And then I calculated the geometric mean here. Geometric mean of this ratio. You can see those highlighted colors here. Right from volunteer number 1 to volunteer number 18. The geometric mean of J39 to J56. So the geometric mean has come as 100.37. Now, not just the geometric mean, because I need the 90% CI of the mean, which means now I have to calculate the 90% CI, this one, lower bound and upper bound. But for Excel sheet, I need to calculate margin of error, because margin of error is required for calculating the 90% CI. But for margin of error calculation, I would need standard deviation. So the Excel sheet beautifully gives you standard deviation by formula called as STDEV, standard deviation. Now the same numbers for volunteer number 1 to volunteer number 18, I am asking to provide the standard deviation. When I enter it, the standard deviation would have been provided. So the standard deviation is here, 3.45. So now I have the geometric mean also. I have the standard deviation also. Now I have to calculate margin of error. Now let's talk about what is the difference between standard deviation and margin of error. Probably I think you all know what is standard deviation. Standard deviation basically means how much data are spread around the mean. So it measures the spread of data within the single sample. These are samples. Describing how much is the variability of this data around the mean, plus or minus 3.45. So this is basically the variability in the sample around the mean. But this is a sample statistics. Number 1 to 18, these are the sample volunteers. So this is what is the sample data. But now, if I want to calculate the population data, that means from the sample, can I estimate the population parameter? This is the mean of the sample. What would have been the mean of the population? This is the standard deviation of the sample. What would have been the population, the standard deviation of the population? So margin of error quantifies uncertainty in the sample statistics while estimating the population parameter. And that is why the margin of error becomes the population. The standard deviation becomes the sample data. Now in the Excel sheet, for calculating the margin of error, there is a function called as is equal to confidence dot t. Now confidence dot t, when you write equal to confidence dot t, Excel sheet asks you three things: alpha, standard deviation, and the size. So you need three things. Now alpha, because we are considering 90% confidence, and at this 90% confidence, we are calculating interval. That is why it is called as 90% CI. So when 90% confidence is been taken, that means alpha error is considered as 10%, which is nothing but 0.1. So I would give this Excel the function of 0.1 because alpha is 0.1. This 0.1 has been taken based on the 90% CI. So now I can give is equal to confidence dot t in the bracket 0.1. Standard deviation I have calculated here, 3.45. Size means how many participants you had in the study. In this study, there were 18 participants. So now I would give this Excel, the data that Excel is asking for, confidence dot t in the bracket 0.1, comma, because he is asking comma, standard deviation 3.45, comma, I would give 18, and then I would close the bracket, and that gives me the margin of error. Now in the Excel, when you put equal to confidence dot t, Excel also has a confidence dot norm. Now when to use confidence dot t like what I have used here, and when to use confidence dot norm, because just below this there is a confidence dot norm also. So confidence dot t is used when the population SD is unknown. I know the SD of the sample, but this population SD is unknown to me. Or the sample size for me is small, just 18 participants. So in either case, I have to use confidence dot t because sample size is small and also the population SD is not known. I know the sample SD, but population SD is not known. If you know this, then you can use confidence dot norm. When the population standard deviation is known or when the sample size is large, then you can use confidence dot norm. That is why I use confidence dot t because my sample is a participant and not the population. Only few people have taken, not the whole population. So when I provide this data, sample is, sorry, confidence dot t, alpha error 0.1 because 90% CI, so 10% error, which means 0.1. The standard deviation is this one 3.45, which is nothing but the cell J58, and 18 is the number of volunteers. I have 18 people. So that gives me margin of error is 1.41. So now I have the geometric mean, standard deviation, margin of error. Now I have to calculate 90% CI, the last two. When I say 90% CI, it's a confidence interval. When I say the word interval, which means there has to be two numbers, the lower number and the higher number. So the lower number is called as the lower bound and the upper number is called as the upper bound. So 90% CI has a lower bound and the upper bound. Now, how to calculate the lower bound? Mean minus margin of error. Mean is here 100.37. Margin of error is 1.41. So the lower bound is equal to mean minus margin of error. So now I did that. The number is 98.96. The upper bound, mean plus margin of error. Mean is 100 plus 100.37. Margin of error is 1.41. So I have given the Excel the work for doing summation equal to sum of geometric mean plus margin of error. Plus because I am calculating the upper bound. The value has come as 101.79. Now I have to apply the definition of bioequivalence. The definition says the ratio which is calculated in the form of geometric mean, ratio of test versus reference, the 90% CI of that ratio should fall between 80 to 125%. So here it is 98.96 and the upper bound is 101.79. That means both the numbers, they are falling in the range of 80 to 125%. This formulation is considered as bioequivalent. So just to revise once again finally, whenever you are asked to calculate bioequivalence, what do you do first? Because definition says 90% CI of the ratio. That means we calculate the ratio. But that ratio has to be in the geometric mean. Then we calculate the 90% CI. And for calculating 90% CI in Excel, we need margin of error. And for calculating margin of error, we need standard deviation. So the lower bound is nothing but the mean minus margin of error, and upper bound is nothing but the mean plus margin of error. And both of these numbers, they fall in the range of 80 to 125%. This calculation is only done for AUC. Similar calculation should be done for the Cmax. And both of these, AUC as well as Cmax, both should follow the same definition. That means the mean ratio, which is the geometric mean, 90% CI of this should fall both for AUC and Cmax within the range of 80 to 125%. If that is seen in the mathematical calculation, we say that both products are bioequivalent and they can be replaced in case there is no other formulation available or the same brand is not available, it can be replaced. Now that was the theoretical mathematical calculation. Now I have taken one example and this is a beautiful example from one of the journals recently published 2023. This is from the infectious disease clinical microbiology journal. And in this example, you can see they have conducted a bioequivalence study and they published it in a journal. And what they did was, this was the for product called as posaconazole, which is the antifungal drug. And posaconazole test formulation versus reference formulation. They tested bioequivalence in the fasting condition and in the fed condition. Now this is fasting condition and this is the fed condition. So under fasting condition, what happened? And under fed condition, what happened? The two formulation, two same PK parameter that we have been discussing for bioequivalence, AUC and Cmax. AUC 0 to T and AUC 0 to infinity. Cmax. I will come to intra-subject variability in a while, but only focus about the definition that we spoke about. We said that the bioequivalence would be said to have, or bioequivalence is accepted when the 90% CI of the ratio falls between 80 to 125. Now the ratio is here and the 90% CI is here. And these numbers are not falling in the range of 80 to 125. They are more than 125. For Cmax also, for AUC from 0 to T also, and from 0 to infinity also. So this particular condition, that means posaconazole, whichever formulation they have manufactured or they have tested, it was not bioequivalent with reference product when it was tested under fasting condition. But when it was tested under fed condition, you look at this ratio 97.41 for Cmax, AUC and T, AUC and infinity, the 90% CI of the ratio. Now these numbers, both for Cmax and AUC, they fall within the range of 80 to 125%. These numbers are out. And that's why they have highlighted, they have made it bold. Whereas these numbers, they are within the range of 80 to 125%, both for Cmax as well as for AUC. So what was the conclusion made by these authors? Criteria used to assess bioequivalence between the test product and the reference product of the posaconazole, formulations were fulfilled under fed conditions. Under the fed condition, they were fulfilled. Bioequivalence was fulfilled. But the bioequivalence was not fulfilled under the fasting condition because these numbers are not within the range. So this is what is the definition and relevance of the mathematical calculations of the bioequivalence. Now quickly, what is meaning of this intra-subject CV? Here you can see the numbers 15.1 for Cmax, 11.5 for AUC, here 13.6 for Cmax, 7.5 and 7.77 for AUC. So this intra-subject and CV. So first let's talk about what is intra-subject. Inter-subject means between two people. Intra-subject means within same individual. And CV is nothing but the coefficient of variability or coefficient of variation. So intra-subject is within individual and coefficient of variation is denoted as CV intra. Now what is the relevance of this CV intra? They say that when CV intra is more than 30%, when CV intra is more than 30%, then you need large number of participants in the bioequivalence study. The study should include large number of participants. That's one relevance of knowing what is intra-subject CV. The second relevance that they say is that when the intra-subject CV is more than 30%, you need to use a different study design called as a replicate study design, partial replicate or a full replicate. So because of that, you need to know what is the intra-subject variability. So intra-subject variability helps us to understand, number one, whether sample size should be low or sample size should be large enough, and whether replicate study design would be useful or we can go with the simple crossover studies. Now, how it is calculated? So intra-subject variability is calculated as, the formula is simple, standard deviation divided by mean into 100. So now, when you look at the AUC, suppose there are 7 volunteers, I mean, say 7 times the formulation has been tested. And intra-subject variability, the mean has come as 35.14. Standard deviation, STD.V, this is come as 8.95. So the formula is SD, which is 8.95, divided by mean, which is 35.14, into 100. So this divided by this into 100. And the CV for this formulation has come as 25.47. So which is less than 30%. So we said that bioequivalence studies, they use intra-subject CV intra, which is nothing but the coefficient of variation in the within the subject. So this is used by the BE studies for calculating necessary sample size. So higher is the sample size, higher is the CV, that means coefficient of variation. We need more participants. And generally they say the Cmax would have higher variability as compared to AUC. And if intra-subject coefficient of variation is more than 30%, the formulation is considered highly variable. So for some products, you might have to do a pilot study and see what is the intra-subject CV. If intra-subject CV is more than 30%, then you have to go for a large sample size and the replicate study design. Now this is my last section of the discussion, which is nothing but the calculating the area under curve using trapezoidal method. Up till now, we just use the concept how to calculate the area under curve, and we defined 4 different methods, or we enlisted 4 different methods for calculating AUC. So just to revise, those methods were planimeter, cut and weigh method, counting square method, and the last method was the trapezoidal rule method, which is a mathematical calculation. So now, next 10 minutes or 15 minutes, I will do mathematical calculation using the area under curve by trapezoidal method. And that would be the last part of my session for the day. This is what is the dummy exercise that I have taken. So I have the time concentrations given from time 0 to time 10. And in the previous examples also, we did not have any number for time 0. So C0 need to be calculated. The investigator, the principal investigator of this BA study, bioavailability study, he would have taken the samples and the concentration from first hour to 10th hour. These are given here. And these are labeled as C0 to C7. C0, C1, C2, C3, C4, C5, C6, C7. Remember here, these are not 1, 2, 3, 4, 5. Because here 1, 2, 3, 4, and then at 5 hours it was not taken. At 6 hours it was taken. Then it was taken at 8 hours, and then it was taken at 10th hour. So this is what is the dummy data which is available for calculating the area under curve. Now what we need to do? We have discussed this formula that area under curve 0 to infinity is equal to area under curve 0 to 1, 1 to 2, 2 to 3, 3 to 4, and 4 to infinity. Now, the previous example was for 10 hours. Just for simplification of the demonstration, instead of 10 hours, I have cut down to 4 hours. This is just for demonstration, so that it becomes easy for us to focus on the numbers. So what I'm trying to do, I'm trying to calculate the area under curve for the whole area. But for this, I have to first draw the plasma concentration versus time curve. So I have calculated here. And I have demonstrated you in the previous discussion, how did we arrive at this Excel sheet graph. So now I have asked the Excel also to give me a trend line. The trend line also has been given. So you can see here at 0 hour, there was nothing because we did not calculate the concentration. But at 1 hour, the concentration was about 71. This was concentration. Then the concentration at C2, it was about 50 hours. Draw a line and you can see 50 hours. 50. For C3, the concentration was 35. Somewhere here between 30 and 40. And for hour 4, it was 25 here. Between 20 and 30. So now I have complete 3 trapezoids. These perpendicular lines I have drawn. The Excel has not drawn. Excel only has drawn this particular trend line. I have drawn these perpendicular lines so that it becomes easy for me to understand how many squares, or not squares, how many trapezoids are seen in my area under curve. So there are 3 clear-cut trapezoids, 1, 2, 3. But There are two more trapezoids. This trapezoid, if I take the data backwards, I would have one more trapezoid here. And one more trapezoid when I draw further. So now I have 5 trapezoids. 1, 2, 3, 4, and 5 trapezoids. The formula, which is standard formula, that is useful for these 3 trapezoids. So middle 3 I can calculate by that formula, C1 plus C2 divided by 2 into T2 minus T1. That formula is useful for this also, this also, and this also. So for these 3, the formula is C1 plus C2 divided by 2 into T2 minus T1. That is the formula for middle 3. But what about the first and the last 3? That is where I put a question mark here. Question mark here. Question mark. But let's first calculate the whichever we can calculate easily, and then we calculate the remaining 2, and then we sum it up so that it gives the area under curve from 0 to infinity. Let's do that. So the formula which I told you, traditional formula, C1 plus C2 divided by 2 into T2 minus T1. That is for first trapezoid, this trapezoid. If I want to calculate for this trapezoid, instead of C1, C2, it becomes C2, C3. C2 plus C3. Instead of T2 minus T1, it becomes now T3 minus T2 divided by 2. The third trapezoid, it becomes C3 plus C4 into T4 minus T3 divided by 2. Now let's put this calculation in place. So C1 plus C2, C1 is here, this one, 71. So 71 is here. 71 plus C2 is 50 here. C2 is 50 here. So 71 plus 50 into 2 minus 1, T2 minus T1, 2 minus 1, divided by 2. So the whole answer for this trapezoid, area first trapezoid, comes at 60.5, which is I put it here, 60.5. Now the trapezoidal area 2, you can see the concentration decreasing, the area under curve is decreasing. So number 2 is C2 plus C3. C2 is 50, C3 is 35, 50 plus 35 into T3 minus T2, T3, 3 minus 2, so 3 minus 2 divided by 2. That becomes 42.5. I have put it 42.5 here. The last, this trapezoid, traditional, which is available with me, C3 plus C4, 35 plus 25 into, it should have been T4 minus T3. So T4 is 4 minus T3. It should have been 4 minus 3 here. That's my mistake. It should be 4 minus 3. And the value comes as 30. The value comes as 30. So now I have the 3 trapezoids. This trapezoid and this trapezoid we need to calculate. So let's calculate for the last trapezoid first. This trapezoid. Now this trapezoid, we know that we need to first know what is the slope, because the exponential decay is going to happen because it's a first order kinetic. So fixed fraction is going to get eliminated. So that fraction we will calculate using elimination rate constant, which is nothing but the slope. So slope is calculated because I need to calculate the area under curve for this trapezoid. So slope is calculated as the formula that we have repeated 2-3 times, y2 minus y1 divided by x2 minus x1. y2 minus y1, y2 minus y1, 50 minus 71. This one. I'm considering these two numbers, time hour 1 and time hour 2. So y2 and y1, I'm considering this one. And I told you that slope is always negative. So 50 minus 71. So 50 minus 71, that comes minus 21. Divided by 2 minus 1, that comes as 1. So the slope comes as 21. So for calculating the area under curve for the last trapezoid, I should know what is the slope. So minus 21 is the slope. But having slope is not enough. I have to use the formula. Now the formula here is C4 divided by slope. C4 divided by slope. Now what was the C4? C4 is the concentration which is available, 25. Because the last concentration here, because I'm calculating the trapezoidal area for this particular section. So C4 divided by KE. Just now I have calculated KE, which is 21. So C4 is 25. KE is 21. So the area under curve becomes 1.9. So I have put it 1.9. So now if I had to calculate the all total area under curves, I have the area under curve for 1, 2, 3, 4. But the first one, this one is still remaining. So I will calculate that area under curve for trapezoid first. The last trapezoid we have calculated. Now let's go to the first trapezoid, this one. So for this trapezoid, we have another formula. And this formula is C0 T1 divided by 2. So again I will repeat. C0 is nothing but the intercept. And we know what is the intercept. C0 is here. C0 plus C1 into T1, which is 1. T1 is 1. Divided by 2. Very simple. So intercept is 83.5 because we have calculated the intercept using the formula. Or you can use a trend line, and on Excel sheet, you ask them to show the trend line on the graph, and that trend line will give you y is equal to mx plus b. And in the mx plus b, the m is intercept. B is nothing but the slope. So mx plus b, the m is intercept, which you can calculate by two methods, which I told you. So intercept can be calculated by using the Excel formula is equal to intercept, and you give those two columns, the time column and the concentration column, and the Excel will give you the intercept. So for this particular example, intercept is 83.5. So 83.5, because if this line goes up and touches backward to the y-axis, it will become 83.5. C1 we already have it. C1 is 71. C0 plus C1. T1 also we have it, which is 1 hour. Divide by 2. So it becomes 77.25. I have put it 77.25. So now I have all these particular numbers in place. And if I want to calculate the area under curve from first to last, right from here up to here, when it touches this particular. So this area under curve up to here, this would be called as total area under curve. For total area under curve for this example, we had 3, which we calculated with a standard formula, C1 plus C2 plus C1 plus C2 divided by 2 into T2 minus T1. The last one we calculated as the C4 divided by KE. And the first one we calculated as C0 plus C1 into T1 divided by 2. So now having all these numbers into place, we just have to sum them up. So 77.25 plus 60.5 plus 42.5 plus 30 plus 1.9. So the area under curve for this particular example is 212.15. So that becomes the area under curve for this example. And this is the mathematical calculation using the trapezoidal rule. So we spoke about planimeter, cut and weigh method, then counting square method, and the extensive calculation that we did using 3 different formulas for the traditional ones, the first one and the last one. This is what called as the trapezoidal method. Now there are lots of softwares that are available. I'm at the flag end of my presentation. I think this slide and the next slide. So softwares for pharmacokinetics. I told you that the simple calculations that we can do on Excel sheet and simple mathematical formulas, those are either they are non-compartmental model, or at the most they are first or single compartment model. For multiple compartment model, if there are so for example, we consider 2 compartments, which means there would be different elimination rate constant for different compartments, and then the calculations becomes difficult. And that's where softwares are available. Bioequivalence centers, BABE centers, they use this software very commonly. Phonics, WinNonLin. There are other softwares also like GastroPlus, NonMain, Monolix, PK Solver. So depending upon the purpose and depending upon the requirement, different companies they use different softwares for population pharmacokinetics or for different calculations. So that's all from my side. Just to revise what we discussed in last maybe 5 to 10 minutes. We started at 2 o'clock with the objectives, and the objectives were to know whether different kind of different parameters we discussed. We discussed Cmax, AUC. Then we talked about the plasma concentration versus time curve. Then we converted that into log concentration versus time curve. Then we spoke about the log can be either natural log or it can be common log. And then we calculated different pK parameters. And we also discussed the bioequivalence formulas, and we spoke about the confidence 90% CI, and the ratio should fall between the 80 to 125% limit. Finally, we calculated the area under curve using the trapezoidal rule. And for trapezoidal rule, I said that we might have the middle easy calculation by using standard trapezoidal formula, which is nothing but the C1 plus C2 divided by 2 into T2 minus T1. But for the first and the last trapezoid, we require different formula. The last trapezoid would depend upon the concentration at the last point divided by the elimination rate constant, which is nothing but the slope. And for the first trapezoid, we need to know what is the intercept. So for area under curve calculation, the two important concepts that we spoke, one is the slope, one is the intercept. Slope is essential for the last area under curve calculation, and the intercept is useful for the first area under calculation. So with this, I think I'm done with my all slides presentation. So I would hand over the session to Dr. Shambo, and maybe then we can proceed for the next discussion.
Thank you, sir. Thank you for this wonderful deliberation. And I think we have some of our questions. Before that, it will be great if you can little bit explain. Already you had mentioned it during your presentation, but basic questions asked by teachers. Why is the pharmacokinetics best studied using log concentration time curve rather than a linear curve?
Yes, I think, sir, there are two reasons generally for using a log concentration. Number one, on the log table or on the log paper, we can accommodate a lot of points, because if I take the log of 100, it becomes 2, which means I can incorporate multiple data points or multiple samples on the log paper. That's the first advantage. And when you convert that traditional data into log data, the line becomes straighter, and for mathematical calculations, it becomes easy. So those are the two important advantages of converting normal data into the log data. Maybe Debashish sir, you can also add if you have difference of opinion or anything.
No, that's the right answer. Yeah.
Yeah, so thank you, sir. So another issue is that another important questions often asked that if two drugs have the same half-life but different volume of distribution. Now, same half-life, different volume of distribution, what differs clinically?
Half-life is same and volume of distribution is different, you're saying. So if volume of distribution is different, then I think the release pattern when the drug is getting eliminated from different segments, the elimination rate constant might differ. So the drug is going into different compartments, releasing from that area. The release pattern might be different. So prediction of when the elimination would happen at what speed, that might be different. So that's what is my maybe logical answers.
Yes, sir. So that is why I think also the loading dose will be different also for
Oh,
that
yeah,
purpose.
yes, generally, I mean, volume of distribution, as I showed in the first slide, depending upon where the drug goes, whether it's a highly plasma protein bound or whether it's extracellular tissues or whether it's a lipid soluble or whether it's a tissue bound. Generally, for more than 1 liter per kg, loading dose might be advisable because then the concentration may not be in a therapeutic range with the normal dose.
Right. So, thank you, sir. And I think we got certain, yes, one questions that had been asked in the chat box from the audience. I couldn't get his name. How can postgraduate students move beyond theoretical understanding and apply pharmacokinetics effectively during their ward visits?
Yes, I think I always keep on saying to my PG students, so when they present any drug review, for example, and they say this drug has a volume 5 liter of volume of distribution. So my next question is, so what? So for every question you say, so what? If half-life is 5 hours, so what? So if they have answer to this, so what, then they can apply it very well.
Thank you. Thank you, sir. And another question that had been asked in the chat box by Dr. Dipti V. When plasma needs to be taken, when whole blood sample need to be taken. Okay, so during the TDM, Dr. Dipti asking that when plasma needs to be taken and when whole blood sample need to be taken
Yeah, it depends
for
upon
therapeutic drug molecule.
it depends upon the property of the drug. If the drug has a more affinity for the RBCs, then the whole blood has to be taken rather than the plasma. Generally, for the drugs which are from the immunosuppressant category, whole blood is advisable. For uh, traditional other drugs, we generally say plasma is okay. But among the immunosuppressant, mycophenolate mofetil, although we say for it has to be taken blood, for mycophenolate mofetil, plasma also could be good enough. So it would be drug to drug specific differences depending upon their affinity, whether to RBC or they are not confined to RBC.
Again, Dr. Dipti V had asked that if after 5 half-lives, 97% drug eliminated and same 5 half-lives needs to reach steady state concentration where rate of absorption and elimination is same. Kindly explain, sir.
Yes, so I think there are two concepts, so two separate parts. Number one is the elimination, and one is the reaching steady state concentration. So I will first explain the first part. So I said that approximately 4 to 5 half-lives would be required for the drug to get eliminated from the body, almost, not complete. So just imagine in one half-life, 50% drug has gone out. In second half-life, the 50% or 50% will go, which means 25% will go. So in two half-lives, 75% drug would go. And likewise, if you do mathematical calculations, after 5 half-lives, approximately 97% drug would be removed from the body. Now, that is where we say almost. So first part is over. So in the first,
Never eliminated completely.
not eliminated completely because some fraction will still remain. Now coming to the steady state concentration. Now when you give the concentration one dose after the second, second after the third, so the absorption and elimination they are happening simultaneously. But after 4 to 5 half-lives, the absorption becomes equal to elimination. That is where the level becomes steady. And from there, we have to give the maintenance dose. So that's the logic of the understanding when actually the steady state level would reach.
Okay, regarding one question that has been asked, that whether to collect plasma or serum or whole cell concentrate. So one more exception or one more difference is lithium, because lithium has a volume of distribution is equal to the total body water, that is intracellular, extracellular and extravascular. Intravascular. So that makes the total body water. So even if the blood is hemolyzed or it is plasma or serum, you get the same concentration of lithium because it does not change. It is equally distributed in the total body water component. Intracellular, extracellular and intravascular. The concentration remains same in the steady state.
Yes,
So
I
this is
think
a question MCQ for this.
correct. Correct. And because it's a monovalent cation, so because of
Yeah,
monovalency, it
moves
distributes
freely
everywhere.
across the vascular compartments.
Yeah.
Right. Uh, Again, I think this already you had also explained during your presentation, because one questions that had been asked regarding the volume of distribution and bioavailability. I think Dr. Atman Jajal had asked that. So, any key points you want to mention on these two important concepts of volume of distribution and bioavailability for our PG students to remember?
So volume of distribution, basically where the drug is going to get distributed. So it all depends upon the lipid solubility of the drug, the tissue binding, the ionization. So a lot of factors, they determine the volume of distribution. But the clinical importance is that if the volume of distribution is too much, then the therapeutic concentration may not reach within required time. So loading dose is the major concern for volume of distribution. So volume of distribution depends upon the dose and the plasma concentration. So plasma concentration, whatever is the dose given, total dose given divided by plasma concentration. That's how we calculate volume of distribution. And bioavailability, I think, which definition you follow, because the regulatory definition is rate and extent of the absorption. The general definition is how much drug is going into plasma concentration, which is unchanged and available for action. But regulatory definition becomes important when specifically you are checking bioavailability of two products, AUC and Cmax of one product and AUC and Cmax of the other product. So I think it's good to know both definitions, and regulatory purposes use the regulatory definition, and for clinical purposes we use the amount of the drug that is reaching in the plasma concentration, I mean in the systemic circulation unchanged form.
Thank you, sir. I think as everyone is asking about bioavailability multiple times, so I also want to ask you, because you are one of the masters in that field of dermatology, and we are talking a lot of about topical bioavailability, and when we talk about systemic bioavailability of a topical drug, what we actually expect. And even if you talk about the pulmonary therapeutics, the bioavailability concept is a little bit different. So, what is your thought on that? And if you just throw some light on this aspect.
Yeah, I think it's about where do you need the drug to have action on. If the action is topical, then bioavailability may not be that significantly important, because the site of action is not going through the blood. Absorption is happening at the local place. For example, in the inhalational corticosteroids, we say inhalational corticosteroids, where is the disease, you give the drug there. And if the drug can reach at the site of action without going through circulation, then there is no point in giving high bioavailability medications, because that would rather result in more toxicity. So where the disease, the drug should go there by whichever route. So if the maybe the place is accessible, like topical and inhalational, then we should give the drug which are having less bioavailability, because we don't want to go through the blood. Topical action is good enough. And that's why we say inhalational corticosteroids, they act topically, and they are not systemically absorbed. So even in children, inhalational corticosteroid would not hamper the growth to much extent as they would do with the parenteral formulation. So that's an advantage of the topical formulations, whether you give through skin or through inhalational route.
Yeah, so when we use topical drugs, so our goal is to have less systemic bioavailability, and that is the study we generally need to do.
Correct.
So, thank you very much, sir. So, I think we don't have any more question. So, may I request Hota sir, because you were there from the beginning. So,
Yeah, it is very interesting actually. I always like this. So this was really eye-opener for most of this. But they have to again prepare and study on their own. Attending a lecture is just beginning. It is like the abstract. So they have to read the full topic. And can you recommend any textbook? We usually recommend Sargel for our MD students. Anything other than Sargel, anything that you can recommend, Dr. Patil?
So in fact, I personally read Goodman, Gilman and Katzensel.
Okay,
And,
Goodman-Gilman is ultimate.
and
Sargent is basically focusing on the kinetics in detail,
yes.
single compartment, multi-compartment, so that they can learn. So, but whenever we ask question, what is clearance? The answer is universal. It is the amount of drug cleared from the plasma. So
No, no,
that is the wrong
that's the
answer
absolute
every time we get.
clearance. Basically, for the students who are listening to this question, clearance is not about the amount. Clearance is about the plasma. How much plasma is getting
Is
cleared from the
eliminated per time.
exactly.
Cleared of the drug
Yes,
per
cleared of
time.
it. Correct.
So, but the answer is universally wrong and it is constant. It is not
Correct.
changing any time.
True. True.
They
Very.
always say the amount of plasma cleared from the body per time.
Correct. So that's where I think concept they need to be clear first, and then the reading becomes more interesting.
Yes. But it was very nice presentation and well organized.
Thank you, sir.
So it is all from your personal experience that you presented. That is why it is more touching.
Yes. Thank you so much, sir. Thank you.
Yeah, great.
So I think we get again two more questions. Dr. Naveen Kumar asking, sir, you calculated equation with a y-axis was not in log. How is that? If y-axis not in log, it would be curve.
So as I said, remember the phrase linear up, log down. So linear up, when absorption phase is happening, linear is fine. When the concentrations are going down, elimination is happening, then you need to convert them into log concentration. Then that would be advisable. So wherever I would have calculated the elimination phase, then it is advisable to convert into the log. And when you are talking about the absorption phase, the linear concentration is good enough.
Another question asked by Dr. Swati Misra. Sir, how can we use this topic knowledge in which area of industrial areas or pharmaceutical sector?
I think this is applicable to whichever sector you go to. Number one, it's very essential when you join the BAB centers. Because, for example, in Navi Mumbai, where I stay, there are lots of bioequivalence centers. So many pharmacologists, they join as a principal investigator or maybe advisor to those centers where this bioequivalence data analysis and understanding is extremely crucial. When you become medical advisor in a pharmaceutical company, when you are designing the studies, especially phase 1, phase 2 studies in clinical research, there also this application becomes important. When you join the medical affairs and when you're comparing your product versus the other product, a competitor product, again the pharmacokinetic, because there are some sustained release formulation, there are some instant release formulation, somebody comes with some innovative technology, and then you have to prepare a compendium saying that how your product is faring versus other. So whichever field you go to in the pharmacy industry, PK knowledge is the foundation based on which you will build your further understanding and discussion.
Yeah, thank you. Thank you, sir. So I think we can conclude this particular
Can I
topic.
can I make a comment here?
Yes,
Yes,
sir.
yes, please, sir.
This is regarding that why the x-axis is in log and y-axis is not in log. I think a simple explanation could be that the response is usually the least response and the maximal response. That stretch is not long, that stretch is not very wide. While if you think of the doses that would be required to produce a given response, okay, minimal response, submaximal response, and maximal response, the stretch of this width of this range of doses may be very, very wide. And in order to accommodate that wide variation in doses, you need to convert that into log scale. So that's why it is semi-log. Okay, semi-log paper you can use, or so I think that is a more easy way of remembering that x-axis is dose and y-axis is response. Dose, because there is a wide range of dose that may be used for developing the dose response curve. So that's why doses are in log scale, and response doesn't really need a log conversion, because response you can accommodate at a small this thing. Okay,
Absolutely, completely agree.
that is one way of expressing it.
Correct.
Thank you very much. Regarding the other thing about bioavailability for topicals, okay, whether it is applied on skin or whether you take it or inhaler therapy in asthma. Truly speaking, when you talk of bioavailability, you are very right. The rate and extent both are important. I'll only have a comment that there cannot be anything regulatory definition and clinical definition. Okay? I always felt that rate and extent is a better definition. You have to consider both, whether it is regulatorily, when you talk of bioequivalence, as well as from the clinical perspective. As a clinician also, anybody would like to have understanding about both rate and extent, okay? How quickly the effect will start, onset, what would be the maximal response, what is the Cmax. If the Cmax is below your minimum effective concentration, it's of no use. So that's why rate and extent are both important, not just for regulatory purpose, but also from clinical perspective. That's my take on this.
Agree, sir.
Third point is, when you talk of the topical application, the more scientific or more precise definition of bioavailability is availability not just in the central compartment. The drugs that act to produce systemic response, there you expect the drug to come in the central compartment, then distributed to different other compartments, different other tissues, including your target tissue. So target tissue is only very few. Non-target tissues are millions. Okay, the drugs reaching the non-target tissue creates problem. Drugs reaching the target tissue creates the desired response. The very ethos and philosophy of bioavailability is availability at the target tissue. But then measurement of availability on the target tissue is not easy. It's challenging, difficult. So we take a compromise that we believe, hypothesize that anything that reaches central compartment, that will ultimately, proportion of it will be reaching the target tissue, provided there is no compromise in the distribution system, etc., etc. Okay. So therefore, but ideally, we would have appreciated a definition what says that availability, rate and extent of availability of the drug following its administration to the target tissue. Now, when you are using a drug for topical application where you need it at the layers of the skin, it should work. Or for that matter, when you are using inhaler therapy in asthma, you are expecting its bioavailability, maximum bioavailability at the target tissue where it should reach. There, in fact, if it goes to the systemic circulation, that is not wanted, undesired.
Correct.
Okay. So the question is that how we can measure that. When I am giving a inhalation therapy, how much of the drug is actually reaching to the bronchial tissue, okay, that is important. But then there are different other ways or strategies by which it is done, how much is delivered, okay, when you are inhaling. And similarly in skin also, even I can take you to the example of, say, miltefosine in the treatment of, okay, leishmaniasis, okay. And there the use of miltefosine in dermal leishmaniasis, people have also done experiments in order to see that how much is actually reaching the layers of the skin. Okay, when you are taking miltefosine orally, how much it is reaching in the layers of the skin. Okay, and even people have also tried to use perfusion system. From one side, it is getting into the layers of the skin. From the other side, how much is getting out, and from that, they are trying to find out what is the availability, how much is residence time in the tissue. Okay, that can also, there are more complex strategies by which this kind of bioavailability is measured. But it's a very interesting area. That bioavailability for topicals is a difficult area, more complex area. Thank you. These are some of the. I'm sorry I could not be present for the total this thing, although I had the desire, but I just joined 10 minutes back. Thank you very much. It was great. Okay. In the initial phase for 5-7 minutes, and the last 5-7 minutes I was there. Okay. But I really enjoyed. Thank you.
Thank you so much.
Patil.
Thank you.
Okay. On behalf of this meeting, I just have one question for all the participants. Name the drugs even if given by intravenous route, the bioavailability is never 100%. Just guess. This is a question to all students. You gave it by IV route, but the bioavailability is never 100%.
So
There are a
without
series of drugs.
without checking Google, please type in the chat box so that we
Yeah.
get that. So once again, thank you, Professor Anant Patil sir, for giving your
An
valuable time.
extension of this question would be, think of a substance which are otherwise endogenously ubiquitous, okay, endogenous substance, but which is never used as a drug, whether you take it orally or as intravenous, because always the bioavailability will be very low. I'm talking of acetylcholine.
Right, sir.
Whether you take orally, it will be degraded by, okay, pseudocholinesterase in the gut, in the liver. It will not reach in the circulation, okay, central circulation. And if you give it by intravenous route, there also there is pseudocholinesterase in blood in sufficient quantity, it will degrade immediately. So it's not going to produce much effect actually. Okay, the effect will be very instantaneous. In the otherwise animal experiments we have used acetylcholine, we see, but then instant effect. But clinically it is not used. Over. Thank you.
Yeah, we just see the response of acetylcholine, but not the
Not
quantity
the
of
effect. Yeah.
acetylcholine in the plasma.
Right.
Yeah.
So thank you very much. On behalf of Indian Pharmacological Society Clinical Section, we want to thank Professor Anant Patil sir immensely for giving your valuable time. So it was a more than 3 hours you were delivering this fantastic lectures, and those lectures were really helpful for all our PG students and those members who had joined today. So thank you very much, sir. Now we are
I
moving.
think one revision may be needed after a few months.
Yes, sir. We will plan.
We can have
And
a
also,
post test also.
yes. So with your permission, as we are recording this, with your permission, we want to put this in our IPS website so that everyone can go through it and revisit uh, this class again and again. Thank you, sir. Thank you very much. So
Thank you.
now,
Thank you.
now may I invite three doyens in clinical pharmacology, we must say. First, Professor Shantanu Kumar Tripathi. Professor Shantanu Kumar Tripathi is currently the president of Association of Clinical Pharmacologists. Welcome, sir. We also have with us Professor Shoilendro Handu, sir. Professor Shoilendro Handu, again, a very renowned clinical pharmacologist from the country. Sir is currently the head at the Department of Pharmacology at AIIMS Rishikesh. Welcome, sir. Thank you for giving us your time. And also, it is our real pleasure to have once again Professor Debashish Hota, sir, one of the
Thank you.
most reputed clinical pharmacologists in the country. Sir is the head at the Department of Pharmacology at AIIMS Bhubaneswar. And also, as we had mentioned previously, sir is currently the editor-in-chief of Indian Journal of Pharmacology. So this session, this is a 1 hour 30-minute session now, the pharmacokinetics in clinical practice. And we have three clinical pharmacologists who will deliver these three topics. May I request our chairpersons, Professor Shantanu Tripathi sir, Professor Shoilendro Handu sir, and Professor Debashish Hota sir to start the session accordingly.
Okay. Yeah. The topics chosen by the meeting that is interesting. So particularly antibiotic stewardship and antibiotic resistance, these are the problems, and we are still looking forward to a solution for that antibiotic resistance, because the rate at which the microorganisms have developed resistance and the rate at which the human beings are producing antibiotic is disproportionate. So it is predicted that by 2030, maybe most of these deadly organisms will be resistant to the common antibiotics. Even if any patient who is hospitalized and in ICU develops this hospital-acquired pneumonia or ventilator-associated pneumonia by Acinetobacter or other organisms, it is very difficult to treat. You see the antibiogram also R, no S. It is all about R's, registered. So definitely we have to find a solution with all available resources, how we can maximize the benefit to save the life of a person, and what are the preventive steps that we can take to control the development of resistance. There are simpler steps also, but are never followed. One thing that was enforced on us during the COVID time, that wearing mask and repeated hand washing, either by soap water or by this alcohol based hand sanitizers, that really helped in controlling a lot of hospital acquired infections. Although the cause of death during COVID was different, but other infections, particularly respiratory and GI infection, have come down drastically. So that works. These are simple measures but rarely followed. Apart from that, we have to protect our resources, whatever we have today. So one nephithromycin introduced last year does not suffice. Maybe very soon we will have resistance against that. So we are looking for some drugs. Have also recently introduced a fluoroquinolone derivative for gonococcal infection this year. But we don't have really many antibiotics developed, or a new mechanism is developed. It is again the same mechanism with a different target. So we are still struggling to find a new antibiotic. Of course, I am not losing hope on the development of antibiotic, and we are actually in the process of getting more antibiotic. But if you see the drugs approved by the government of India, so it is all about weight loss, diabetes, lifestyle diseases, obesity. So these are the things government is more interested, or the industry is more interested, because like a neuropsychiatric, yes, we are getting new antipsychotic drugs, almost one or two every year. Like lumateperone has recently introduced, and new drugs have come. But the target where suffering is more for a brief period but very deadly, that is anti-infection, we don't have much antibiotics. So we are now in the process of getting a good therapeutic this thing, and here oncology is another area where there is a profound immune suppression and risk of infection is quite high, and how to utilize the knowledge of kinetics in infection and geriatrics and in other uses, that we have to know. Of course, the topic is not exclusive on antibiotics. It is about the kinetic or the clinical or the practical utility of the knowledge of pharmacokinetics in prescribing drugs in various indications, particularly geriatrics or the cancer patients, or in hospitalized patients with infection. So we have three eminent presenters, Dr. Manjunath, Dr. Rachna, and Dr. Soumitra Mandal. So now I will hand over the topic to Dr. Santanu Tripathi to add few points on this. Sir, your mic is switched off, mic muted.
Yeah, I'm sorry. There is not much to add here. I would only say that the three topics that have been chosen are very apt, very relevant. Okay, one is the PKPD of antibiotics, particularly I think in the critically ill people, where they are under the treatment with multiple medicines, okay, multiple medications, and where the bioavailability of the antibiotic when they are given, that can also be influenced. So there again, it is the whether the traditional PKPD concepts are enough, or you have to also think of some other okay, strategies or other principles, other concepts, insofar as tailoring the treatment with antibiotics in the critically ill. That is a area which is a challenge area. That's one area. Second, there is also another session on geriatrics, antibiotic use, PKPD in geriatrics. I think that is also going to be very, very interesting. And third, of course, the in malignancy, in oncology, what is the role of PKPD of antibiotics. PKPD of drugs in geriatrics, kinetics of geriatrics in geriatrics. In oncology. So all these three areas are very important, and we are looking forward to have absorbing sessions by three different young doyens in clinical pharmacology in the country. And I think without waiting further, we can just invite them. I'll just hand over to Dr. Shailendra if he has a couple
Yeah.
of words to say before we start. Professor Shailendra Handu, over to you.
Thank you. Am I audible?
Yes, you are.
Okay. I had committed to, join this workshop today, but unfortunately traveling this time. So as a result, I am in the midst of a traffic jam. So in any case, I think it's my pleasure, and I'm so happy to join this deliberation today on three important and vital topics. And first of all, my regards to Dr. Tripathi and Dr. Ota. And thanks to Dr. Shambo for organizing this workshop today. And I think all these three areas, oncology, infections, and geriatric medicine, geriatric age group, probably constitute a very high level uh, of burden in terms of burden of disease and in terms of morbidity and mortality. And I think these are three areas where optimization of drug therapies required in terms of improving drug safety and also first improving the efficacy of treatment. And we are following the conventional methods of PKPD and titrating the dose as of now, but we have to move to the next level where we can optimize therapy and reduce the adverse events associated with drugs in these three cohorts of disease. So I think it will be an interesting session today, and all the best to the three speakers. And we have three uh, young clinical pharmacologists who will be presenting and deliberating on these three areas. So back to Dr. Shambo to initiate the proceedings. I think we can call the first presenter.
Thank you, sir. Thank you very much. And I think just like your traffic jam, I think pharmacokinetics is also like a traffic jam. So they're just like.
I mean, these are vital areas. I think it will be very interesting to listen to the speakers.
So thank you very much. So now may I invite Dr. Manjunath and to tell us about its implication on oncology.
Good afternoon, sir. This is Dr. Manjunath here. And first and foremost, my regards to all my seniors present in the discussion over here. And I thank IPS for inviting me to deliver the lecture or a topic over here. So my topic is pharmacokinetics in the oncology practice. So I work in the Tata Memorial Center, Navi Mumbai, Kharghar. So wherein it's like an oncology. So basically I'll be discussing mainly on the oncological aspects and how we can bridge the PKPD models and with the real world evidence in the oncology in the Indian setup. So as already introduced about the talk by our eminent seniors, so the cancer drugs show a high variability and complexity compared to the non-cancer drugs, and the PK changes for these drugs across the cycles because of the drug toxicity having an effect on the organs and the enzyme modulation. So we are aware like there are certain definite differences between the cancers and the non-cancer drugs. We know like non-cancer drugs being like have a wider safety margin and a steady state dosing and have a more predictable effects. But compared to and oncology drugs, they have a narrow therapeutic index and the absorption is variable due to the existing gastrointestinal issues and the drug interactions. and the tumor has to get penetrated or it has to reach the site of its action, and it is altered by the liver mets, and the end organ dysfunction causes a non-linear elimination of the drug also. So all this will lead to the higher interpatient variability, which requires a dose in the individualization also. And one more thing is the data or the dosages as suggested by Dr. Handu sir, like we follow certain practices. Sometimes it is coming from the Western practice, or we go for the flat dosing or the weight-based dosing. And there are definite Indian data exist wherein the dosages are not tolerable in the Indian context patients. So I will be discussing mainly the translating the real world data for dose optimization by using the PKPD or the pharmacometrics approach. So why this dose? As previously discussed, there is an importance of the precision dosing, wherein everybody is saying like, yes, precision dosing is important in this field, in every field. And even the multiple FDA guidelines are available to implement the real world data for the individualized dosing. So we do or don't do the enough pharmacokinetics or the population pharmacokinetics approaches or not. So this is not a capability problem, but this is a context problem. So we need to extend the research beyond the trials into the routine clinical practice. That is, bring the real world data into the research. How do we do that one? Either by using the sparse or the opportunistic samplings, time varying covariates, and adherence and the dose modifications. But these do have a major challenges, like the data will be very sparse and the background noise or the noisy data will be there, missing time points data, non-adherence, as well as the heterogeneous endpoints. Still, this is useful because it will provide the real variability that is present and improves the generalizability and enables the learning healthcare systems and supports the precision medicine and bridges the research with the practice. So what it will finally lead? So the efficacy, it becomes the effectiveness by incorporating the real world data. So how do we do the population pharmacokinetics or the PKPD analysis? What we do, like, initially collect the data by giving the drugs, collecting the samples, do the analysis, understand any variabilities is present or not, and build the models using the different softwares. And then we evaluate them and then finally use it in our patients. So now I'll just discuss a couple of studies wherein we can understand its importance. So in oncology, like a majority of our cancers are in Indian context is the head and neck cancer patients, and few of these cancer patients will have the nasogastric tube or the Ryle's tube, what we say. So in which we cannot administer regularly the whole tablets for them. This calls for crushing the tablet, which that is to alter the formulation that is already existing, mix it with water and administer in the through the Ryle's tube. So whether this will alter its kinetics or not is the question that came to us. So what we did to crush the tablet and compare its kinetics with the whole tablet kinetics in the head and neck cancer patients. So what we did an open label randomized parallel group single dose PK study. We administered 150 mg of whole tablet as well as the crushed tablets in the two different groups, and obviously the time points will be different for the two different groups, and we did the study and collected the data, and subsequently we did the analysis, non-compartmental analysis. What we have found that the crushed and the whole tablets, the kinetics or the Cmax, AUC and the Tmax are entirely different. So nearly 25 to 30% of the levels have been increased by crushing the tablets, which is reflected in the Cmax as well as it's in the AUC also. So then, as said, absorption rate is unchanged, but the bioavailability and the has been increased, which is nothing but mainly due to the clear formulation effect. So if we see this, the dose optimization, if we see what's the level happening here, with the 150 mg of the crust tablet, 150 mg of the whole tablets. When we see that the levels have increased, so we try to simulate which dose of the crust formulation will produce an effect similar to that of the 150 mg of the whole tablets. So if we take that 150 mg of the whole tablet of the erlotinib levels, what it produces, and compared with simulated with further different dosages of the crust formulation, that is 70, 80, 100, 110. So what we observed, the levels of 150 mg of the whole were falling or similar to that of the 110 mg of the crust formulation of the erlotinib. So 110 mg is equivalent to the 150 mg. So how can we show that? This is the graph which it has shown by the simulation. So 150 mg of the whole tablet, this is the dotted line, okay, and different concentrations or the AUC or the concentration response relationships of the crust formulation. So if we see that the levels achieved by the 110 mg, of this have been in parallel with that of the 150 mg of the whole tablets. So suppose if we give the same 150 mg of the crust formulation to a normal cancer patients, the drug levels will increase, which will ultimately cause the drug toxicity. So this is one way, one of the thing what we have observed, and we have advised our consultants in the patient management. Next, regarding the antibiotics, where we are continuously, having a main problem, like next level of antibiotics are not available, especially in the case of the emergency or the ICU settings. So we know like the colistin, there are a large number of clinical challenges stating that this is the last line of antibiotic and it has a narrow therapeutic window which can cause the toxicities. And especially in the case of bone marrow transplant patients, it has a high PK variability to. And one more thing is the dosing regimens that usually in the hospitals follow are different, and they are different from that of the product label too. So what we did is similar. What we can do usually in these situations is to compare the drug levels of different dosing regimens, or take one dosing regimen, get the kinetics and simulate it for the different dosing regimens. So this is what we did. That is, we planned the study, we submitted and got the study approved. Subsequently, we administered as per the FDA label of the drug. That is 25,000 international units per kg body weight in three times a day as an IV infusion over 30 minutes, and calculated the PK at the first dose as well as at the steady state. We did the drug levels. This is what we observed, the drug levels are falling down. What the PK appeared to be. Then we did the PK response analysis, compared what the AUC or the concentrations at the steady state and the responses that we have achieved there. So what we found that from the POP PK analysis is that the creatinine clearance is significantly affected the clearance, and the body weight affected the volume of distributions. So what we observed, the current dosing practice, that is the 25,000 international units per kg body weight 3 times in a day, has led to the decreased number of patients who are achieving the required steady state concentrations. So we have simulated for the different dosing regimens, that is the 3 million units given in 3 times a day, or 4.5 million units given twice in a day, or 9 followed by 4.5 million international units twice daily. So what we observed, these concentrations have to be present if the drug has to be safe and effective. That is, the average steady state concentration should be more than or equal to 2, and the Cmin should not be more than 3.33. So by the current dosing regimens, if we see the number of patients who are achieving the target attainment, that is these two factors, are less than 20%. Okay, and this is the 40%. if we modify the dosing regimens, that is mainly the 9 million units, sorry, 9 million units loading dose followed by 4.5 million units twice in a day achieved the number of patients to go beyond the 80%, but the toxicity was not much increased when compared to the existing standard of dosing approach. So we have suggested our consultants to modify the dosing regimen to for 9 followed by 4.5 billion units BD, or so these are just a couple of examples. Multiple things can be discussed in the pharma field in oncology also. So the path forward is to undertake the pragmatic study designs, sparse sample modelings, and the clinician modular collaboration, context aware regulations. Another approach, another path of research, what we can do is, especially in the field of oncology, to bring a drug into the therapeutic drug monitoring practice, because we are well aware that these have the narrow therapeutic index, and very few drugs have been identified for a therapeutic range. So we have to bring these drugs into the therapeutic drug monitoring practice. So whether we are ready or not. So it's not a luxury. It must be context driven as said. It should be selective and ethical, and we are ready if we adapt it wisely. Thank you.
Yeah, this is a real life example how two same drug in different forms can alter the bioavailability, especially in cancer patients. Cancer patients, as you have rightly mentioned, they receive multiple drugs. They have immune suppression, they have GI problems, they have cardiac problems, they have other organ, liver, kidney issues. So there is a different kinetics. They cannot be compared with healthy individuals. So obviously, in an altered situation, and we are changing the formulation, most hospitals they do it because per kg, so they just crush it and give that desired amount. I can add one example here: hydroxyurea in sickle cell disease. So far, until last year, we had only one formulation, 500 milligram capsule, and the dose was 20 to 30 milligram per kg. So they used to open the capsule, then give it arbitrarily the expected dose. That was really not very helpful. Of course, we have not ventured into estimating hydroxyurea, but this can be a danger also. And we have some examples where this changing the formulation or crushing the tablet that initially increases the bioavailability but decreases the AUC because of the early metabolic transformation. So that is also a possibility, particularly with phenytoin. So that happens. So anyway, but you are more focused on cancer therapy. So Dr. Santanu, can you add any point to Dr.
Yeah.
Manjunath?
First of all, I must congratulate Dr. Manjunath. It is
Thank you, sir.
really thought-provoking to many of the people listening today. And this is a clear example how a clinical pharmacologist can actually extend support in optimizing treatment. Okay, and you are doing the right job there at your
Thank
center.
you, sir.
I have some concerns. Of course, it is the need of the hour, and you are trying to support to the extent possible. But there are definite challenges in these kind of real life or real world and pragmatic kind of study design. And of course, the greatest challenge would be how are you going to control the confounders? Okay, every patient is different, and when you are taking sample, sampling time is also very important. Okay, how are you adjusting that sampling timing? And when you are finally going to measure the concentration of the drug, so that how are you adjusting that? Okay, that is also would be interesting to know. And secondly, because every patient is different and their morbidity, and particularly in terms of the handling of the drug, whether it is absorption, whether it is distribution, protein binding, okay, clearance, everything. So everything will be different in each individual patient. And trying to get some kind of meaningful conclusion out of this kind of exercise and forwarding it to the clinician to titrate the dose accordingly. uh, it has its own inherent challenge, but then you have thought about this and you are trying to otherwise extend support, and gradually I think through experience, through trial and error, you can refine it further and further. Regarding the crushing, so far as crushing is concerned, yes, this is done in routinely in clinical practice, as Professor Hota also mentioned that opening the capsule, taking the powder, these are common kind of experiences in clinical setting. But to what extent that is advisable, that is also a big question. And for many times we have seen that the anti-TB drugs, tuberculosis, treatment, many formulations were not suited for pediatric dosing. So there also, when you say that tablet is going to be based on the body weight or based on the body surface, the tablet, whole tablet is being crushed, whole tablet is being broken, 1/4, 1/5, 1/6. There is only one score at the base. The tablets that can be broken, until unless there is a score in the tablet surface, we should say that it is not to be broken. Only if there is a score, it can be possibly broken. But many tablets, they are also coated, surface coated. There, any surface coated tablet, enteric coating tablet, is not supposed to be broken or crushed. So these are also formulation issues, and how, when you are doing this, whether the concerned nurse or the physician who are at the helm of affairs for administering the drug, whether they are keeping this in mind when they are crushing, these are also issues. So far as the colistin is concerned, or for that matter any antibiotic, there it is not just I think adequate to talk about the concentration in blood what is available, but there are other factors also. The different antibiotics, they follow different kind of kinetic factors are involved in their availability, etc. This is a new area, the translational pharmacokinetics in the area of oncology. It's very challenging. I think I'm sure, like you, there are other people also must be working. At least it is stimulating our interest, and maybe after listening to your presentation today, at least so far as I am concerned, I'll try to go to the literature and try to search some literature whether there are other people also working in this area. But I thank you profusely. Great job. Go ahead. Thank you very much. And we can ask questions now. Ask
Sir,
for other
whatever,
participants. Yes, please.
sir, whatever points you have highlighted are the real practical problems that we do face, and they are the real challenges. Means
Yes.
like, should we crush or not is the first question. If there is no other treatment go for the patients, there comes a situation, yes, we have to take a step, otherwise the patients will be in the palliative care, some treatment has to be given, and they have to get this type of formulation. So even then, is it safe or not, whether it is giving good level or not? So in this regard, like we have undertaken a study for the 6-MP also, 6-mercaptopurine, wherein we found that by administering the drug in a crest formulation, so the levels have been increasing. So we have suggested, we collaborated with one of the pharma and developed a new formulation that is like a pediatric friendly formulation. And in this regard, ICMR has supported this, and a new formulation of the 6-MP has come to the market with the from our clinical trial simulations as well as the data also. And the next one, the colistin or antibiotic, definitely, like I mean, the in the intensive care setups, the drug levels what they are achieving and the state what they are like, we have to take a necessary step whether these levels what they are achieving are as per the standard requirements or not. Suppose if the CLSI guideline says like 2 is the level, should be present. Whether our patients are achieving that level or not, we are trying to see that one. When the dosing regimens are not able to reach to that one, definitely they have to they have modified the dose, because
I think for some antibiotic it is not just the MIC, or it is not just the concentration that matters. The time factor also comes there.
yes,
Okay.
sir. Agreed, sir.
And secondly, in one of your slide, you have mentioned about cholesterol that C mean minimum concentration that should be more than 3.3, whether it is more
It
than
should be
or
less
less
than.
than.
If
In
yes, it
your
should be less
presentation,
than.
it was showing more than. It should not be
Right,
more than. It should be less than.
right. It should be
Okay.
less than. It should be less.
Yeah. So one challenge was what was actually intriguing me, that when you are doing these pragmatic trials, it may be very difficult actually to control the confounders.
So in this case, what we do is like we keep when we develop the models. So once we develop the base model over and above, what we do is we will keep the different covariates that you are referring to: the liver function, the albumin status, the creatinine clearance, the patient's body weight, the clinical condition, all the things, or what we call them as like an SOFA score in this case of the
Right.
ICU patients. All the things will keep them, and whether the base model is improving or deteriorating by adding these covariates or deleting these covariates, then accordingly those covariates emerge out as an crucial ones. That's how like we will modify the dosing practices by adjusting or accounting to those covariates, sir.
Right. You see, regarding the crushing, again, one has to think of there might be also medicines which are otherwise designed in a manner keeping in mind the gastric transit time. Maybe what is the area of the gut from where the drug is going to be absorbed. Accordingly, the formulation is developed. But
Right.
when you are crushing it, you are actually exposing the most of the materials at the very beginning at the gastric lumen itself. Okay,
Right.
thereby maybe the sufficient concentration, again it's the question of acid sensitivity, acid resistance, all these factors will come. The molecules, number of molecules reaching at the critical area of the intestine, maybe in the small intestine or later part of small intestine, that is actually the area from where the drug is absorbed. So it may not reach there, but otherwise anything instead of a solid tablet, if you give it in a powder form, the common sense would say that bioavailability will increase. Okay, so if otherwise if the absorption will be more, so that is okay. But then you are very right that if we can accordingly adjust the dose, depend keeping in mind what is the bioavailability, what is the Cmax, what is the Tmax, etc., keeping that in mind, and accordingly you have suggested to make the changes in the dosing. And side by side, I would request that in your next set of experiment, you can also try to think of having some kind of pharmacodynamic endpoint or effectiveness endpoint. If you can also try to associate with that,
Sure.
that I think will be add much more value to
Sure.
this.
Sure.
Thank you very much. Over.
Thank you, sir.
Yeah, very enlightening, actually, personal experience that he has shared, Dr. Manjunath. So, one of my students has joined in pediatric surgery oncology, medical oncology in Actrec recently. So, she might be interacting with you. I will give you a reference also.
Sure.
Sital.
Sure,
She
sir.
is our MBBS student from 2013 batch. Anyway,
Okay.
that is personal matter. But as far as the topic is concerned, cancer definitely is a big topic, and in an altered situation, altered body condition, it is very difficult to attain a therapeutic concentration and therapeutic goal. So we are looking forward to a better cancer therapy, and this is the area where maximum drugs are developed,
Sir, yes.
immunosuppressants and cancers. So
Yes.
definitely it will pose more challenge, and all these disease-free survival or progression-free survival, these are the two endpoints what most trials they focus on. How long the person can survive with his life and how much. That is what somebody said in a conference, that only to give the property statement to he'll make them alive till he hands over the property. That's all. So thank you, Dr. Manjunath.
Thank you, sir.
And we wish in future we'll have more such personal experience from you. This is very
Sure, sir.
delightful to have interaction with you.
Thank you, sir.
And we'll move over quickly to our next speaker. And Dr. Shambo's next speaker is on antibiotic stewardship.
Yes, yes.
Okay. Has he been present?
Yeah.
Yeah, Rachna, are you there?
Yes, yes.
Yeah. So antibiotic stewardship, that is now a big issue all over the world. We are looking for how to safely use the antibiotics. And because as I have mentioned in the initial part that our resources are very, very limited and the organisms have become smarter with time. They thrive on this adverse situation for them and they are getting more used to this exposure of antibiotics and they are resistant to most of the common antibiotics we have. And the rate of antibiotic development is really, it is very, very disappointingly slow. And we have to use our available resources, even our common sense or repurposing or anything that we can do, how to safely use the antibiotic and correctly use the antibiotic. So Dr. Rachna will now speak on this. So over to Dr. Rachna, please.
Thank you, sir. Thank you so much. First of all, my kind regards to Shantanu Tripathi sir, Pandu sir, and Huta sir. And I'm very thankful to Shambo sir for having me here on this platform. And in addition, I congratulate Dr. Manjunath for the fabulous work he has been doing in oncology. So I'll share my screen. Kindly let me know if the screen is visible. Is my screen visible?
Yes, yes, it's visible.
Yeah, please go ahead.
So I'll be talking a bit about the PKPD considerations in the dosing and how do we optimize the dose of antibiotic with some examples in the critically ill patients. So there are certain case scenarios here in front of you. If you see in all these situations, the antibiotic which we are choosing varies. Let's take first example, a child with community-acquired pneumonia with mild to moderate symptoms. Here, in cases of community-acquired pneumonia, you will first see that the patient is having mild to moderate. Can you treat it on the OPD basis or IPD basis? Then secondly, you will think of what could be the possible organisms here. In the bacteria, it could be Streptococcus pneumoniae, it could be H. influenza, it could be E. coli, gram-negative or Staph aureus, possibly. Then there could be atypical organisms like Mycoplasma or Chlamydia in certain cases. Then it could be possibly viral infection, which is influenza. So there you will choose an antibiotic for a OPD-based treatment like amoxiclav if required. If you suspect it is a viral, then you might not even give any antibiotic. So if you see the second case scenario, a patient with acute febrile illness. Here, it could be possibly malaria, dengue, it could be enteric fever, it could be scrub typhus, it could be leptospira. So when you are choosing a empirical therapy here, if you suspect it's malaria or dengue, you might not give antibiotic therapy at the first place. But if you think it could be scrub typhus or leptospiral infection, then you might give doxycycline as an empirical first-line therapy. Third case scenario is a patient operated for inguinal hernia. Here, it's an example of surgical prophylaxis. The patient does not have any infection as of now, but we are giving an antibiotic to prevent the infection. So in certain cases where there is no implant, like in pediatric patients, there is no need of any antibiotic here because it's a clean procedure. Whereas in adults, when we are putting a mesh, there you can use a single dose of cefuroxime, which is sufficient. And if cefazolin is available, that is a preferred choice. If you take the fourth example, patient with suspected necrotizing fasciitis in the emergency setting or the IPD setup. Here, first of all, you will admit this patient. So inpatient treatment will be given. And the organism suspected here, it could be strep pyogenes, it could be Streptococcus aureus, there could be anaerobic infection as well, or the gram-negative infections. So it's kind of a polymicrobial infection that is there. And you we'll choose an antibiotic which covers both gram positives, gram negative, as well as the anaerobes here. So maybe Praslin-tazobactam you'll start, and if you feel that there is a toxin production here, it's a cellulitis that is there is necrotizing infection is there, you might add a agent which is having antitoxin effect for initial few days of therapy, which is clindamycin. So here, in all the 4 situations, we chose a different antibiotic. And the choice not only depends on the suspected pathogen and diagnosis, but also on the setting we are in the and also the severity of the infection. So there are various guiding principles for choosing an antimicrobial. First and foremost, infecting organism. What antibiotic spectrum do you need based on your infecting organism you are suspecting? Then what is the site of infection? What are the patient factor? Is it an elderly patient, a pregnant female, a neonate, or children, or an adult? Then what could be the resistance pattern? Is the patient coming from for the first time from the community, or is it suspected to be hospital acquired? Is there any evidence or history of prolonged hospitalization in this patient? Okay, and also the safety and tolerability. And another important point is PKPD, which we are focusing on today. So PKPD is an important guiding principle for choosing the antimicrobial therapy in septic patients. So let's talk about 2 cases in relation to this. So case 1, this is a 2-year-old child, post-operative case of appendicitis with a suspected post-op peritonitis. On the POD 6, till then the patient was fine, improving, but then started developing the fever spikes. The current antibiotics the patient is on is injection meropenem, and the weight is 10 kgs with a normal serum creatinine. Procal is raised and CRP is also raised. Now, investigations were sent. We sent the blood culture, urine culture, drain culture, and urine culture came out to be sterile. Drain culture grew Enterococcus faecalis, and blood culture report is still pending. Then the consultation call came to us, and we reviewed this patient. And if you see the TLC is raised, there is fever spikes are there, procal is raised. And this is the culture report, which shows that the brain culture has grown Enterococcus faecalis. The organism is susceptible to vancomycin, teicoplanin, linezolid, and chloramphenicol, and resistant to other antibiotics. The blood culture report is still pending. Now, we advise to add injection vancomycin at a dose of 60 mg per kg per day in the divided doses every 8 hourly over 1 hour infusion. Now, why 1 hour infusion? Because vancomycin, if given by a rapid bolus or within few minutes as a rapid infusion, it can lead to red band syndrome by release of the histamine in the body. So to prevent this, and this is a preventable side effect, it's not a hypersensitivity reaction. So to prevent this, the vancomycin need to be given over little prolonged 1 hour infusion. Now, we also advise to continue. Why continue when we have the culture report in hand? Because the blood culture report is still pending. So we ask them to continue injection meropenem at the dose of 200 milligram IV per kg every 8 hourly over 2 to 3 hour infusion. Now, why 2 to 3 hour infusion? So we'll come to this in the next slide. And we also ask them to monitor the serum creatinine review after 24 hours with blood culture report. So why prolonged infusion for meropenem? Because now there are certain guiding principles, PKPD indices, which guide us in giving how we want to dose the antibiotics. So certain antibiotics, they follow a concentration dependent killing. Means the killing is dependent on the peak concentration reached, means the Cmax. Higher the Cmax, the better will be the killing for these antibiotics. And then they rapidly come down below the MIC. Okay. So for these antibiotics, they have a long post-antibiotic effect. So efficacy is still maintained when the levels are below the MIC. So for these, the PKPD index is Cmax by MIC. And so these antibiotics are given as a large initial dose intermittently. If you see for aminoglycosides, the earlier guidelines used to say BD dosing. But now all the guidelines, including the WHO ICMR, they mention as OD dosing for amikacin gentamicin. So earlier the dosing was 500 milligram IV BD. Now amikacin we are giving as 750 milligram IV OD. So OD dosing, we have a better efficacy and lesser side effects. Okay, the nephrotoxicity, because we give kidney some time for the drug to be eliminated, and there is lesser nephrotoxicity if we give by the OD dosing. Now, there is another subset of antibiotics which follow time-dependent killing. Means the killing depends on the time it remains above the MIC. See, if you see this in the lower B figure, the red one is showing the single dose given high dose, and then it comes below the MIC. And if you see the green chart in the B figure, it's intermittent dosing, the divided doses are being given. And if you see the T more than MIC, if you add up for all these three, it's the TDS dosing. It's more than what you would get if it is given as a single high dose. Okay. So here the killing is better if the time which is more than MIC is longer. So it's like 70 to 80% of the dosing interval, it should be more than MIC. The T max should be, the T more than MIC should be there. So here we give it as a frequent dosing. So either the TDS dosing or QRD dosing, or as a continuous infusion. And for example, the beta-lactams, the carbapenems, they follow time-dependent killing. So we give it as a frequent dosing for continuous infusion. Now, if intermittent dosing, they should be given as a prolonged infusion. Okay. So if you see, this is a diagrammatic representation of what will be, how the concentration time curve will be there. So the blue one shows if meropenem is given as 1 gram IV TDS over 30 minutes. So this 0.2 is the MIC, and the levels go up and then they rapidly fall down below the MIC. And if you add up the T more than MIC for the blue curve, and if it is given as a 3-hour infusion, which is shown in the orange curve, and if you add up the T more than MIC for all the 3 dosing intervals, the T more than MIC is more for a prolonged infusion. So the better efficacy is there if we give the beta-lactams and carbapenems over a prolonged infusion. Now, why we are saying 2 to 3-hour infusion? Why not 6 hours? Why not 8 hours? Why not continuous infusion? Here, we also need to consider the stability of the antibiotic once the drug is reconstituted. For imipenem, the drugs start degrading after 3 hours. For meropenem, it starts degrading once reconstituted after 4 to 5 hours. So, for the easy memory, we say that carbapenems, the duration, the prolonged infusion time should be 2 to 3-hour infusion is sufficient to have a good efficacy. For certain antibiotics like beta-lactams, like piperacillin tazobactam, they have a good stability over 24 hours. So they can be even given by the continuous infusion. That's perfectly fine. So on follow-up, they continued, they followed our advice. They gave vancomycin and meropenem. The patient condition improved. We got the blood culture report after 3 days, which was sterile. So we stopped meropenem and vancomycin was continued. So let's take another case from surgical ICU. It was a 38-year-old male patient with the alleged history of road traffic accident with blunt trauma abdomen with grade 3 pancreatic injury. It was referred from outside to us, and exploratory rhipidotomy and repair was done, and the patient was intubated with central line in situ and drain in the lesser sac. Ongoing antibiotics, meropenem, metronidazole. If you see, the meropenem dose is not correct, 500 milligram IV TDS for an adult patient. And the TLC are high, the patient is having fever, CRAT is normal, inotropic support is not yet needed. There are certain devices in situ. So we usually do the clinical pharmacology rounds in situ regularly. So during the rounds, we ask them to stop metronidazole since it's a double anaerobic coverage. We ask them to give meropenem over 2 to 3 hour infusion in the adequate doses, that is 1 gram IV TDS here. No clinical deterioration as of now, but if fever spike persists, then they were asked to send the paired blood culture, 1 culture from the central line and 1 with the aseptic precautions from the peripheral site. Okay. And then the patient condition started deteriorating with inotropic support requirement. NORAD was added and the patient was already intubated, and blood culture, paired and drain culture and ETA culture was sent. Now, surgeons stopped injection meropenem here and added injection tigecycline in view of deteriorated patient condition. So if you see 10th and 12th, the CRAT is now increasing. There is inotropic support that has been added. The patient condition is worsening. But blood culture report came out to be positive for Acinetobacter baumannii. And if you see the culture susceptibility report, it is only intermediately susceptible to colistin and resistant to all other antibiotics. Now, so what advice did you give if you are a clinical pharmacologist here? Give the definitive therapy with tigecycline only because the patient started improving, or change the antibiotic as per the culture report. So here there is another PKPD principle which you need to understand. I'll discuss it in the next slide. So blood culture report, it was IS to colistin. Now for colistin, specifically for colistin, it is never reported as S. It is either reported as IS or R. So if IS, for practical purposes, you can use colistin. We advise them to stop injection tigecycline and start with injection colistin or polymyxin B here. So we'll discuss the principle behind this. So tigecycline, it is follow a two-compartment model. So there is this central compartment and there is this peripheral compartment. So when we give the drug IV, it rapidly get distributed to the peripheral compartment. And it has a very high volume of distribution of around 5 to 7 liters per kg. So for, let's say, around 70 kg person or 100 kg, let's say, the volume of distribution is 500 to 700 liters, which is very high. And it gets redistributed to lungs, adipose tissue, bone, liver. So the concentration that is there in the intravascular compartment, which is the blood, which is the central compartment, is low, which is not sufficient for the killing of the organism, infected organism. So because of that extensive tissue distribution, the low plasma levels are reached. And in addition, it has around 60% of biliary or fecal elimination and around 50 to 20% of excretion is via the renal route. So what clinical implications does this PK understanding have? So tigecycline can be considered as one of the last resort antibiotic for MDR infections, which are intra-abdominal infections or skin soft tissue infections. It is not a reliable agent or antibiotic for treating bacteremia because of the low plasma levels which are reached. And if you see the microbiology do not report the susceptibility pattern of tigecycline in cases of blood cultures. Why? Because of this, to prevent the misuse of tigecycline in bacteremia cases. So this is an example of selective or cascade reporting. And it's also not a good agent for UTI because the elimination is majoritarily by the fecal elimination and does not reach adequate concentration in the renal system. So if you see the black box warning, earlier the tigecycline was having that it can increase the all-cause mortality. Why? If you use it in the patients with bacterial infections in the blood, bacteremia, there it is not able to achieve the adequate concentration, which can leads to increase in the all-cause mortality. So be careful when you are using, if you are suspecting bacterial infections, the blood infection, bacteremia, then tigecycline might not be a reliable agent for treating bacteremia. Now, why we ask them, and when we say polymyxin, which one to use? Is it called polymyxin E, which is colistin, or polymyxin B? They both have, they belong to polymyxin. So they have the similar antibiotic spectrum, but they differ in the PK properties. And the PK properties is very important here. See, if you see colistin is a prodrug. It is the inactive form, which is available CMS. In the body, it gets converted into the active form, which is the colistin. Now, this conversion itself, it has a very high inter-individual variability. The CMS itself, it has a predominant renal excretion, and the colistin, which is active form, it has a non-renal clearance. And if you see for polymyxin B, it is predominantly having the non-renal clearance, and it is itself in an active form. It does not require conversion. Okay. So in the down box, I have written how do we do the conversion? How do we calculate convert the CBA units into the CMS units? Okay, so this is clinically required. So on the follow-up, we asked them to stop injection tigecycline and give the definitive therapy with injection colistin. So if you want to give colistin, because polymyxin B might not be adequately available in various areas, so or in the pharmacy. So if polymyxin B is available, that is a better choice here because it does not require renal dose modification. The patient was having renal impairment here, creatinine clearance around 50. And if you're giving colistin, then you need to give a modified dose based on the creatinine clearance. So loading dose remains the same, which is 9 million international unit, followed by maintenance dose, which is 3 million international units, IBPD. If it would have been a normal creatinine clearance, the dose is 4.5 milligram IBPD. Okay, so if you see here, there was certain delay in stopping tigecycline, and that is acceptable because there is some hesitancy in switching when the patient is improving. And you also need to be careful and look into the WHO aware. These agents, tigecycline, linezolid, colistin, polymyxin, they belong to the reserve list of the category and only reserved for the MDR infections, which are, there is no other resort that is available, alternative. So on follow-up, the drain output was minimal, the surgical site was healthy. Another reason here why we chose colistin and not tigecycline, apart from that, the PK, which I told, is tigecycline, it has a very broad coverage. Okay, it covers MRSA, it covers gram-positives, negatives, anaerobes, the enterococcus, etc. So almost very broader coverage it has. So colistin, it has a narrow coverage for gram-negative infections. So when we have an option available, we narrow down in the definitive therapy from a broad coverage to a narrower coverage. So patient improved over time, we continued colistin for 10 to 14 days, and then later on we discharged this patient. So now coming to the principles in the critically ill septic patients, there is a change in the pathophysiology. There is accompanying or progressive vital organ dysfunction. We are giving inotropic support. We are giving ECMO. Which also leads to changes in the PK. And in severe infections with MDR in organisms, there is around 2 to 4-fold increase in the mortality if the right antibiotic in the right doses is not given. So right dose in a non-critically ill patients may not hold right in a critically ill septic patient. So certain PK changes I'll talk about is the fluid shift. There is a shift from the intravascular to the interstitial compartment, leading to the third space collections in the septic, the critical ill septic patients. The hypotension, which we treat by giving aggressive fluid resuscitation, also adds to the interstitial fluid accumulation. In addition, there is a change in the volume of distribution because of this. For the hydrophilic drugs, there is increase in the volume of distribution. So there is decrease in the plasma concentration we wanted to achieve. So basically for these hydrophilic agents like beta-lactams, vancomycin, aminoglycosides, we might require loading dose to achieve the initial therapeutic concentration. For lipophilic agents, there is no much change because they are lipophilic. So another important point is hypoalbuminemia in these critical ill septic patients, which decreases the plasma protein binding. And because of that, there is increase in the concentration of unbound form. So if you alone see this part, we might not need to change the dose or we might need to decrease. But on the other hand, more free drug is now available for action. And on the other hand, more of free is also available for elimination. Okay. So for ceftriaxone, let's say it has 85 to 95% plasma protein binding. There is around 2-fold increase in the volume of distribution and clearance as well. So we instead need a higher dose of ceftriaxone in these critically ill septic patients. And the drugs with a higher plasma protein binding, we might need a TTM guiding dosing. And this is another component, augmented renal clearance, which is often missed. It's basically because of this SIRS. That is, we are administering the inotropes, we are giving crystalloid, we are doing fluid therapy, aggressive fluid therapy. What it does is it increases the cardiac output and also decreases the vascular resistance. And because of that, there is an increase in the renal blood flow. And this renal blood flow increase leads to increase in the GFR. Now, there are certain risk factors which, if those are present, we might suspect ARC here, like young age, if it's male patient, severe trauma, inflammation, burns, surgery, pancreatitis, etc. So in this state, there is hyperkinetic state, there is increase in the creatinine clearance to more than 130 ml per minute per 1.73 meters square. So we might need to do the TDM guided dosing, dose optimization. Certain drugs we can give maximum approved dose. For certain, we can increase the dosing interval. We can give prolonged or continuous infusion, or we might switch from a non-renal eliminating agent or give a combination therapy when required. So even if an appropriate antibiotic therapy is given with the active antibiotic as per the culture susceptibility, patient outcomes may not be optimized due to the inadequate drug concentration that is reached at the site of infection. So it can lead to subtherapeutic exposure of the renally excreted antibiotics, especially in the young males. So if we see the prevalence, multiple studies are there, and the prevalence, it ranges, some says that if the ICU stay is more than 7 days and ARC occurs within 1 day, in more than 60%, it is within the 24 hours. Another study says that the prevalence is around 30-40% with the onset within 3 days of the ICU admission and the duration of 5 days, and it basically goes off in the next few weeks. So it's rarely captured routinely and go unnoticed. But if you see the impact, can you see this, the mean, the free T more than MIC levels, if there is no ARC, around 90% of the patients, they achieve the adequate T more than MIC levels for the antibiotics, for meropenem and peptides here. If there is a presence of ARC, it's reduced to only 60%. Okay. And it's a predicted probability of 100% T more than MIC. So higher is the creatinine clearance, there is lower probability of achieving the 100% FT more than MIC. Okay. So what to do? For certain drugs, like beta-lactams, which are excreted by renal route and follow time-dependent kinetics, like amoxicillin, clavulanic acid, piperacillin, tazobactam, ceftazidime, tazobactam, etc. There, you can just prolong the antibiotic infusion strategy or give it by the continuous infusion because they are stable for around 24 hours. So that can be done. For certain hydrophilic drugs, which are excreted by the renal route, and the stability is issue like meropenem, there you need to increase the dose, okay, beyond the standard dose, which is 20 milligram per kg. You might need a higher 40 milligram per kg dose IVTDS. For vancomycin, you can give a higher dose based on the TDM. You can do AUC by MIC guided dosing. So periodic re-evaluation of these patients is needed because they rapidly move from ARC to normal and then impaired renal function. So these patients with the impaired renal function, the lipophilic and high albumin bound antibiotics, which are primarily metabolized in liver, like digoxin, they are predominantly by bile. And in the hepatic impairment, you might need to reduce the dose because it increases the half-life by 40%. For hydrophilic antibiotics, which are primarily eliminated by kidneys, they require dose modification based on creatinine clearance. So for time-dependent kinetics like beta-lactams, carbapenems, etc., the dose reduction is a better strategy than decreasing the frequency. For the drugs which follow time-dependent kinetics like aminoglycosides or fluoroquinolones, they're extending the dose interval is optimal choice rather than decreasing the dose. So let the dose be same, but you extend the dosing interval to preserve the Cmax by MIC. In presence of ECMO circuit itself is another PK compartment, which is involved, which leads to absorption of the drug degradation also there in the circuit. So the VD of hydrophilic and high plasma protein bound is affected like ceftriaxone. For voriconazole, it can bind to ECMO circuit due to sequestration of voriconazole leading to drug loss. So there you need a TDM guided dosing. PD concentrations, the site of infection is really important. You might be choosing a right antibiotic at the right dose, but if it is not reaching at adequate concentration at the site of infection, then the patient won't improve. Like for certain, let's say the culture grew A. bomine, which was IS to colistin, and you choose colistin in cases of VAP or HAP. But IV colistin does not reach adequate level in the lung. So what to do? You need to give IV. Along with that, you need to give nebulized colistin to achieve the adequate levels in the lung parenchyma. Same way, daptomycin. It is inactivated by lung surfactant. So it's not the right choice in cases of HAP or VAP. CNS penetration is another important issue for amphotericin B, colistin. They do not adequately reach the concentration. So if in cases of CNS infections or meningitis, you might need to give it by the intrathecal or intraventricular route. Presence of biofilms in indwelling catheters, it limits the penetration, it inactivates the antibiotic, and it is involved in the resistance. So for these penetration of certain positively charged antibiotics, it hinders the presence of, hinders in the presence of biofilms leading to subtherapeutic concentrations. So that need to be considered, especially in the long indwelling catheter presence. So this is to sum up that there are pathophysiological alteration in the critical ill patients, like because of the presence of SIRS, ARC, MODS, or hypovolemia, and the supporting measures which we are using. In addition, you need to take care of the patient factors, understand the focus of infection, the source control, what is the pathogenicity, is it an MDR pathogen you are dealing with? And also it is important to look into the PK/PD indices of the antibiotics and do the dose optimization of the antibiotic therapy. So now we are moving from the conventional TDM, where we were doing for aminoglycosides, vancomycin, voriconazole, to a model-informed precision dosing, where in addition to the blood levels, we also consider the clinical covariates, patient characteristics, and we feed it into the software to calculate the adequate dose in that subset of patient. So take-home message, we need to appreciate the PKPD principles of antibiotic therapy while taking into consideration the focus of infection for rational and individualized dosing regimens. And the PKPD, they alter in the critical ill septic patients. So loading dose is recommended, especially in the critical ill patients for vancomycin, TICO, colistin, polymyxin B, fluconazole, and ganciclovir. Loading dose does not require dose modification. It is a maintenance dose which requires dose modification in creatinine, based on the creatinine clearance. And incorporation of PKPD modeling and pharmacometric approach in dose optimization can improve the patient outcomes in critically septic patients. So thank you so much, everyone.
Thank you, Dr. Rachna.
Yes, sir.
It was very exhaustive, but I will still say it is too little because it is still a big problem. You have answered or you have this attended most of these critical issues. So one of the points that I wish to add to this choice of antibiotic is the cost. So initial presentation with so many circles around the main circle. So cost is another factor because most of the patients have to buy it. All are not insured. And if the patient has insurance, first they will exhaust all the insurance amount, private hospitals especially. So that is a big Indian problem. And choice of antibiotic, that is again, you have talked about in a specialized hospital where you have PKPD facility and expert guidance is available. But it is really a challenge for resource depleted hospitals where only your clinical judgment is available. No other instrument or expert opinion is not available. So there is a big problem. So right now, as you mentioned, we have only few drugs: vancomycin, meropenem, piperacillin, tazobactam, piperacillin, avibactam, and ceftriaxone, like that. In this context, I will tell in AIMS CTVA surgery, Dr. Bisoi, who has operated upon one of my relatives for aortic valve stenosis, 3 days he has given piperacillin, tazobactam. Next, after 3 days, patient was discharged from IV antibiotics, switched over to this cefuroxime. That's all for another 5 days. So 8 days, patient was fine, no other infection. Of course, it was a clean surgery. But what you mentioned, like necrotizing fasciitis or gunshot injury or road traffic accident, where there is a high risk of gram positive, gram negative anaerobic infection and maybe extending to deeper tissues, that is a real challenge. Even for septic abortion, gynec department really struggles most of the times where in the middle of the night a lady comes with septic abortion. So that happens. So choosing the right antibiotic at the right point and keeping him or her alive, that is a big challenge. And this is what we should apply, where we should apply the knowledge of clinical pharmacokinetics and pharmacodynamics. And still a lot of things need to be done because our antibiotic resources have become more precious because of the nature of the disease is expanding very fast. So thank you. And Dr. Santanu, to add anything?
Yeah, again, I congratulate Dr. Rachna. It's wonderful to listen to you. And this is what I had been cherishing for decades, that yes, clinical pharmacologist has a lot to actually contribute in day-to-day optimization of patient care. And you are precisely doing that. Okay. And that too in case of critical care setting. You have elucidated the uh, critical areas in this challenging setting of managing a critically ill patient. And we must remember, I think there are some other issues like possibilities of drug-drug interactions and how that is also impacting on the availability, tissue availability of the antibiotic or the microenvironment of infection reaching, whether antibiotic is reaching in sufficient concentration. You are very right. I really like that we just cannot afford to think of kinetics in silo. We have to always think kinetics in terms of pkpd, and then again not just pkpd, ultimately to what extent it is deriving the benefit to the patient when you talk of pt pharmacotherapeutics. And the other component also I won't leave here, that is pc, that is pharmaceutics. When you talk of starting from pharmaceutics, what is the dosage form, how you are giving, that you have very nicely mentioned about the okay uh, the one shot or whether is in infusion, and the duration of the infusion, everything becomes important. Okay. And you have also taken example and you have demonstrated that this choice of the product, choice of the formulation, choosing the route of administration, deciding the rate of infusion, frequency of administration, the loading dose size, everything becomes important. But again, as Dr. Professor Hota has mentioned, that the critical care unit is blessed to have you there. Okay. But truly speaking, throughout the country, the innumerable number of critical care units, every day so many patients are being treated. Okay. uh, so what's happening there? Okay. To a great extent, it is only the clinicians would say it is their clinical wisdom, clinical acumen. Okay. But then I think time has come, it's not enough, you have to go beyond, more objective support is required. I was just wondering that when we would get the advantage of this kind of the wisdom to be translated into some kind of okay uh, ai support. Okay. Whether if you could feed these data, this information, then whether there could be a prompt by the ai that for this patient, because everything the final decision has to be customized for that patient, personalized, every patient is different. So keeping that in mind, even in the same patient, that close monitoring of the renal function is also to be done, as you have rightly pointed out, that augmented clearance to normal clearance to compromised clearance. Okay. So, and that is going to have great impact on your desired effect, desired benefit. So You have mentioned about the host factors. You have mentioned about the antibiotic factors from the perspective of the given antibiotic, and also the microenvironment. Okay, that is biofilm is also another issue in critical care. This thing, and of course the target tissue availability. Cost has been mentioned by Professor Hota, but I think in critical care at least, okay, because it's very intense and for short period of time the patient remains, okay, receives treatment. Uh, so yes, to a great extent the patient doesn't have much to say really. Patient has
No choice.
patient's voice, patient has no choice, patient has no voice there. Okay,
Yeah.
and then because it is expected that it is a short term this thing, okay, for 5 days, 7 days, 10 days, 15 days. So I think most of the cases, even if the patient is given a choice and given a counseling, most of the time patients will not say no if it is otherwise expecting that it is to otherwise giving more. But at the same time, I would agree with Professor Pota that yes, cost is a very important factor. Even in critical care, for 7 days in a critical care unit, total cost of treatment, if it is not supported by insurance, it might be too
True.
huge for most of the average patients. So that's a big area, and it is there where you also need to think of, okay, relatively uh, more economic formulations without compromising with the quality of the formulation, etc., is also important. Multimorbidity and polypharmacy. Polypharmacy is a rule rather than exception in critical care. And the more the number of drugs, more is the chance of adverse drug-drug interactions. Though that also is going to impact on the patients. Okay, whether safety issues are concerned or desired benefit is concerned. But I am really very impressed, and I look forward to more Dr. Rachanas in more of our critical care units. Thank you very much. Thank you.
Thank
A
you, sir.
few points from my side, sir. Just 1 second. That polypharmacy, yes, we have conducted a small survey for our undergraduate students here. How many drugs the patient was on before death in ICU? The average number was 12 plus minus 2. So
Of
10 to
course.
14 drugs in average given. Forgetting about the dental care and all, it is the medicines that are prescribed. And
But
this
I
is
would
the
say, Dr.
number.
Hota,
Yes, sir.
I would say, Dr. Hota, apart from other situations, chronic treatment, long term care, in critical care, most of the time, my take is that polypharmacy, most of the time, is more rational in critical care rather than in an aged person who is suffering from multiple morbidities and receiving multiple medicines, polypharmacy. So here probably the percentage of proportion of medicines, because the definition of polypharmacy is very peculiar. It is five or more, which is again is a very arbitrary. Okay,
Arbitrary.
and particularly in Indian context, when you also have a couple of them are fixed dose combination, then whether each of those active pharmaceutical ingredients in the fixed dose combination, whether you should, I would say they should also be counted. Okay, so when you say five medicines, that is we have to think of not five formulations, five APIs, active
Yes.
pharmaceutical ingredient. So definition of polypharmacy itself is requires a relook. It has to be readdressed in any case. But otherwise, today's program is extremely fascinating, and I really learned a lot out of this. Thank you very much. Over,
So one
Dr. Hota, you are also
Yeah.
telling something. Yes.
Yeah. In ICU, neurologist comes, he examines, he prescribes some medicine, patient continues. Then psychiatrist come because of anxiety or something, or he was crying, so some medicines are prescribed. Then the medicine specialist will come, cardiologist will come. So everybody prescribes, but nobody gives a thought what exactly the patient is having. So it is probably the biggest challenge for a clinical pharmacologist to review the entire medication list the patient is receiving in an ICU, in a critical care setup. And nobody actually gives a thought. Who is in charge of that? A critical care nurse. Everybody is just giving their
Let me
part of job. So that
let
is
me
the
let me
challenge.
let me let me draw the attention of Dr. Shambo. Think about this is this thing that prospect of deprescribing in a critical care unit.
No,
Think
that
about
is
that.
what I was just thinking. Everyone is
Deprescribing in
prescribing.
critical care.
So everyone is
Okay.
prescribing, as Hota sir was mentioning. So at least clinical pharmacologists should be there to de-prescribe. So we need
Deprescribe,
to
right.
we need to popularize this concept amongst us.
Let us give this task to Dr. Rachna. We want to see a series where you have actually successfully deprescribed, and that has been to the benefit of the patient.
True,
Let's see.
true,
One
true.
point
Thank you.
I will like to make, sir. On one hand, we are saying that we do not have enough antibiotics. We do not have any antibiotics in pipeline or near, approval. And on the other hand, we are giving antibiotic excessively. So this is excess versus excess of antibiotics. So recently, I came across one patient in ICU with a triple inotropic support with septic shock, and she was given ceftazidime, avibactam, aztreonam, separately tigecycline, metronidazole, vancomycin, and then there was another drug, tigecycline, that was going on. So 5 to 6 list of antibiotics from the private hospital. She came to us, and they had prescribed each and every high-end antibiotics they could thought of. And in addition, there was colistin also in that list. So 6, 7 antibiotics. So on one hand, we are saying, okay, use the antibiotics rationally. And on the other hand, we are not understanding what coverage do we need, what coverage is this antibiotic is going to provide. And then we are just giving them in combinations कि कुछ तो कोई तो ड्रग एक्ट करेगा, कोई तो एंटीबायोटिक इस पेशेंट को बचा लेगी. So I think this mentality first we need to change. We need to understand why do we need, what coverage do we need, and then comes the concept of rational use of antibiotics.
And
Very
in
true,
your
very true.
presentation also, you mentioned that at least in one patient, you have said that you asked them to stop tigecycline, but they were a little reluctant. They continued for a couple of days more. So you are also deprescribing, okay, that way. Maybe sometimes it becomes difficult to convince the clinician to stop it, okay, but then it's important. Very good. Thank
Okay,
you.
Dr. Rachna, you mentioned about the albumin concentration. Actually, I started a study in PGI when I was about to leave, but it was not complete. That how much plasma albumin is required to bind the expected amount of drug, particularly phenytoin. So if it was a preliminary data, never published because the sample was very small. So if it is more than 2 grams per deciliter, plasma protein binding is clinically not affected. So, or the clearance is not changed. If it is below 2 grams, then there is a problem. So then we have to also make a further study to establish how much albumin is necessary to have altered pharmacokinetics of highly protein bound drugs. So this is a challenge for all of us. So we can conduct a study, those who have TDM facility or any drug analysis facility. So we can conduct a study, and I want data from whole of the country, not a particular hospital or particular setup. This is essential because we want to establish something for national level. Right.
Good. Right. Dr. Handu is there if
So
he
I
has any
think
comments.
he is.
Yes, sir is there.
No.
Sir is there.
Yeah.
Andu sir, can you hear us?
Maybe he's
Maybe,
not
yeah.
having stable net connection.
Maybe.
So thank you, Dr. Rachna, then.
Thank you so much, sir. Thank you so much, everyone, for having me here. Thank you.
Yeah. So actually, we are actually running short of time. There is an IPS meeting also. So now our next topic is focus on geriatric prescribing. As you all know that geriatric population, whether it is 60 or 65, that is still a question. And whether it is 70, that is the new concept of geriatric. Okay, so what happens in geriatric? There is a gross change in pharmacokinetics and pharmacodynamics of the drugs that are changing, and people are surviving longer, people are living longer, of course with comorbidities, and multiple drug usage is there, and people have to face the drug interactions and the cost, everything. And we need to learn more about this prescribing in geriatric pharmacology and geriatric drug prescribing. And I invite Dr. Soumitra Mondal for his deliberation on the topic focus on geriatric prescribing. What are the key points to be taken before prescribing or choosing a drug for a geriatric population, and what are the background informations needed before prescribing, and how the patient needs to be followed up. Dr. Mandal, please.
Thank you, sir, for kind invitation. I'm audible?
Yeah, please.
Can I able to share my?
Yes, please
No,
share.
yeah, you start sharing
Please
your
share the
slide.
screen.
Share screen.
Yes, it is now full screen also.
Okay. Thank you, sir, for kindly invite me in these lectures. This is a sudden invitation. Actually, yesterday only I got information from my colleagues that I can. There was one lectures. Can you able to deliver? Today's I am listening whole the pharmacokinetics discussions and all. And today's my lecture is mainly on based on this pharmacokinetics, how actually we are can able to control the geriatric prescribing and others. So before going that, can anyone tell like what is actually how many of you encounter after giving benzodiazepine or diazepam and patients sudden fall occur? Anyone have any incidents of that? So there are lots of actually this type of incidents happen within a geriatric population. So today's lectures, what we actually I try to cover is that why actually the same dose, the adult responding differently to the drugs. What are the common medications which actually causing harm and required reconciliations? What are the newer criteria or model change our practice or clinical practice? Because we are discussing pharmacokinetics, but at the end, the dynamics of the effects, which are actually more important. And what practical tool we can apply for tomorrow also, like in a previous discussions only, the sir is telling that AI applications are there. So we will discuss all those things in my lectures. So before going that, as we know that there was a increase of geriatric populations. Currently, we have around 20 to 30% populations which are due to survival and modern medicine improvements. There was a lots of populations are now going towards the geriatric, means more than 65 years age, and then we already know that there was they are more trained to polypharmacies. They have a lots of polypharmacies, and which actually can potentially cause drug-to-drug interaction. So there was a list of drug is there which is having high prevalence of potential inappropriate medications is there, beams is there, and the surveys which is conducted and results on studies conducted which is showing actually out of these 12% of the in India only 12% of the products which may be come as an PIMS as per 23 BS criteria. So what actually these why these things actually suddenly change in geriatric populations? We are actually mainly concentrate on today all the pharmacokinetics, their parameters and others, and we are actually getting some factors which actually affecting the effect of these drugs or changing the pharmacokinetics parameters. So what actually change? What actually the physiological changes happen in pediatrics? If we see, we can see that there are lots of change occur physiologically, but few are very important, which is we should remember to prescribing. So first thing is that kidney function. So with the progression of age 65 and more than there was a change in the kidney functions. There was a decrease of the kidney functions, which is one of the main parameters, one of the main functions which can alter actually our clearance of the drugs. And once the clearance is decreased, the drug will be more try to accumulate and can cause toxicities. Then there was a change in a hepatic mass, which can actually change in the metabolism. So that is also important. Other than that, in elderly populations, there was a more decrease of the bone mass and muscle mass, along with that increase of the fats, which can alter the volume of distributions, and which altogether can alter the PK parameters, like in a volume of distributions, half-life. So these changes, along with that cardiovascular, gastrointestinal changes, which all actually majority of these systems physiological function gradually age-related decrease occur. So which alter our which can alter our functions in a pharmacodynamic levels. So so what actually happening is that this age group, lots of comorbidities. There was alterations of the alteration of the kidney function test, the kidney functions, the alteration of the hepatic functions. There was a cardiovascular complications there, volume of distribution alter. So lots of comorbidities there, and then for that reasons there are as a multiple drugs are also using. Along with that, some of these specific populations already have some genotyping variations. Although age is not altering the genotypic variations, but these genotypic variations like CIP 2C9 variations, which is responsible for warfarin and others, or these variations actually can affect more towards the elderly patients. So these altogether, along with that, there are a lots, along with these multiple medications, actually these elderly patients popularly take over-the-counter medications and herbal medications also regularly with a minor complaint. So these altogether can lead to severe form of drug-drug interactions, can change the PKs of the drugs, and which can affect its overall dynamics. So what actually changed? What are the PK what actually changed in a PK? We grossly distributed in a absorption, distribution, and metabolism phases. So in these regards, absorption phase, although there was a delay in the gastric emptying and altered pH, but it is actually not altering the absorption of the drugs. It is actually having little or less clinical importance rather than other things like distribution and metabolism and elimination, which actually having more effect towards clinically relevant. Like in case of distributions, I have already discussed that the population increase tend to form more fat masses, so which increase the prolonged half-life of the lipophilic drug like benzodiazepine groups, or decrease lean mass or total body weight, which alter the hydrophilic drug distribution. So this all together, like if it is a lipophilic drug, and in these lipophilic drugs, they will be having prolonged half-life, so there was a chances of accumulation, so then toxicity can occur in and then if this is a hydrophilic drug, so there is a total body concentration will decrease, so more free drug will be there, and which may require the dose adjustment. So regarding metabolism, what we can see is that there was a change in hepatic blood flow, and which can change phase one of the metabolism, like an oxidation and reduction phase. So what happens is, and mainly the phase two is actually phase up. So some of the drugs can affect benzodiazepine and antipsychotic statin. They are actually having prolonged drug action because of the decrease of the hepatic blood flow and the metabolism phase. Similarly, in renal eliminations also, that we know that each age actually each progressing of age, like more than 65, there is a gradual decrease of GFR, loss of cortical tissues. Renal function is gradually decreasing, so that can decrease the renal clearance, so the drug will be more accumulated, and like those drugs which are mainly eliminated through renal route, like an aminoglycoside, digoxin, or metformin, they require maybe the dose adjustment and renal monitoring. If the therapeutic drug monitoring is there, they require the renal monitoring, because this changing in the clearance can altogether changing the drug can act prolonged, and which can change the dynamics. Now we already, these kinetic parameters is changed. Along with that, there are some dynamic changes occur. Some of the cases there was an increased sensitivity, and some of the cases decreased responsiveness occur. So anticoagulant, like directly acting anticoagulant, insulin, or long-acting oral hypoglycemic like sulfonyl ureas, antipsychotics, opioid, they train to, there is an increased sensitivity. So lower amount of drug also can cause more toxicity in these elderly patients. And then there are sometimes receptor responsiveness also decreased due to variations in neurotransmitter and receptor concentrations. So beta adrenergic systems responses may decrease with the progressing of age. So this can lead to response. So this also we have to consider within when we are changing kinetics and within a dynamics concept, that these can be changed. So this altogether can change. Now we have actually lots of changes. We know theoretically that these can be changed. So changing renal can change the half-life, can change the renal eliminations. But when we are practicing clinically, we actually, it is very difficult to remember all the drugs and others. So there are just some tools are there, and actually updated criteria means they are, list is there in a geriatric populations, which can actually guide us to treat these patients. So there was a BS criteria of 2023 updated now recently 2025 actually came, which is based on mainly the BS criteria 2023, and then stop and start version 3, which is actually screening tool for the elderly people, people's prescriptions, and screening tool for alert the right to treatment. These two module charts are there, which are mainly helping us to guide when we are screening actually that elderly patients, which drugs we can use or which actually we can think carefully before prescribing. So these two criteria, AGS BS criteria and stop criteria. So AGS BS criteria, but the main problem is that it is mainly concentrated on American A, but main features is that these criteria actually concentrate on potentially inappropriate medications in an elderly age. So you can they are giving the list of the drugs which you can have to think about the drug disease interactions. You can think like an NSAIDs in a CKD, then sedative in dementia. These what should you focus? Where should you focus? That is actually their guiding. But the problem is that this is mainly US centric. We don't have a exact data and other in our populations. And stops and start criteria, which actually giving list of drug 2023. This is the list of drugs where you can, they are suggesting in each systems that what are the drugs you can stop or think about the stopping because of chance of potential drug interaction and other pharmacokinetic changes, which can all can having that potential drug adverse effect. So there are currently to 2023 there is expanded to 133 stops and 57 start criteria drugs. They are in different phases. So these are the two tools which can use. But first thing is that these tools are now when we are using in specific groups, we can concentrate on only few drugs also, because we are not regularly encountering like a P drug concept. Like we are not regularly going through all the drugs. So whatever drugs in your practice you are looking, that you can use in your you can check from this stop and start criteria, and you can go through that pharmacokinetics, what are the expected changes, and you can make your own dosing schedules and others based on this. So this we already understand that these aged geriatric patients like more than 65 years, there are the physiological changes which can alter our pharmacokinetics. So we can discuss 2 or 3 in the point of clinical pharmacological point of view. So 2 cases I put, one we got in our residency time, and one other from our hospitals currently. So there was one patient is there, which is aged having Mr. R having 78 years of age, hypertensive, have a arterial fibrillation, and CKD. Patients came to visit medical genetics department. So patient is that time currently having digoxins, warfarin, amlodipine, omeprazole, and diazepam. Patients came with a little bit of confusion, repetitive fall, and increase or high INR. Now, they test there in a medical genetics UIP2C9 variant is there they suggested some of the changes, and they refer to our clinical pharmacology departments. So we go through all the medications, and then we are thinking that it is a 78 years of age patients, what we can do in these cases. So we start about the reconciliations. So what are the potential here, these drugs, what are the potential drugs which we think that can change due to age? So the drugs which may go through the kidney, because the 78 years of age, there may be, and already it is in the CKD patient, so kidney function, there probably alteration is there. There was an alteration of warfarin metabolism, because UIP2C9 variant means that warfarin toxicity can also occur. And we already discussed like a diazepam, which is like this group which is trained to cause more toxicities because of increased responsiveness, increase of volume distribution. All we have to consider. So what actually we done at that time is that first thing that we follow that what we are discussing actually, that these lots of drugs when there we are trying to de-prescribing. So these patients, first we are doing is that there was a no clear cut indication actually there that why diazepam is actually prescribed. So when we are taking the history, we get the information that patients have some problem in sleeping and others. So long back there was they prescribed diazepam, and patient is actually continuing that medication for more than 6 months. So we stopped the diazepam as there was a renal clearance, patient is CKD patients, there was a decrease of the renal function, so we adjusted digoxins. Patient, although not due to age, but a warfarin with a CYP2 vessel, which is more prone to cause adverse reaction or warfarin toxicities, we reduced the warfarin. And after when patients next time actually came visited, patients came with an improved cognition, stable INR. We in our hospital actually that day there was no psychiatry department. Actually, the patients sometimes required actually for their sleep and others. Actually, some counseling is actually required to de-prescribing. Not only the patient's relative also, but as we have only limited psychiatry facilities in our hospital. So what we have done is that we tell to visit later on, but somehow patient stop the diazepam, not they don't go for psychiatric counseling, but patient improve. So then that's next case which got in our hospital. The patient previously visited lots of outsides, and then our orthopedics department patient visited. This is a 82 years of age female patients with a type 2 diabetes, osteoarthritis, with a depression and mild cognitive impairment is there. Patient visited to orthopedics and pediatric psychiatry department. These patients actually we came encounter, it is not a referral actually, so we go for some other discussions within with a discussion about the area reporting. And that time actually this case came, and sir tell that okay, you please go through this case and suggest what we can do another. So that case, when we are saying, the patient actually came with a dizziness, recurrent hypoglycemia and fatigues, and the current medications that time patient is in glimepiride, sertraline, ibuprofen, lisinopril, and lorazepam. These medications currently that time patient is there. Now, what actually go for area reporting, but as a clinical pharmacologist, then I tell that not only the reporting of the areas is required, also there was a requirement of the reconciliation. Maybe we can think. So we take that patient to our department and we actually go through these cases. So there was a we find out that glimepiride, which is prone to cause recurrent hypoglycemia due to reduced renal clearance along it. So we are thinking so, and then ibuprofen, which is can cause along with ACE inhibitors can cause increased nephrotoxicities. The patient is 82 years, which is that time the kidney function test report is, I don't remember, it is not there probably. So, but it is expected that 82 years there is a less renal function is means like not good. So, and along with that, prolonged use of NSAIDs are there, and then lorazepam we already discussed that which is cause sedation. Compared to diazepam, it is causing less sedation, but it is can cause sedation for weeks and also cause memory impairment. So what we do is that we suggested to discontinue glimepiride and switches to sitagliptin these patients, and we actually also suggested to do the GFR calculations. So we suggested kidney function test so that even sitagliptin also reduce creatinine, it can go to it can actually lead if it reduce GFR, actually sitagliptin dose also can also change. So, but initially we start with a low dose and we can suggest them, and actually patient is not willing to go for a metformin, and with the previously they have a history of metformin with a GI disturbance, so we suggested sitagliptin. I suggested that it should be ibuprofen. We counsel them and tell that better to stop ibuprofen with a replace with a topical NSAIDs, physiotherapy, and counseling, gradual tapering of the lorazepam within a cognitive behavior therapy, relaxation and sleep hygiene we suggested. And after few 1 month later, when we again inquire actually through follow means by phone, they have hypoglycemia resolved. There is a renal function is that time stabilized. Patients is that after stopping the lorazepam, patient is more improved the alertness and mobility is also, and then most importantly that reduced fall is happen. So what actually these happen, not only these actually this age group of patients, there was a fertility and due to microbiota alterations. What happened is that this group of patients actually happen, there is a gradual decrease of the microbiota, which can leads to alteration of the drug absorption and which can leads to actually the PKPD alteration only. And this group of patients actually more prone to toxicity of the paracetamol, gentamicin, and all those drugs. So, what we are actually discussing, sir, even that Patil sir is suggesting for a ICU patients, that actually same can applicable to in our way also. We can actually generate some models and others, but for that actually we required a huge amount of data. So randomly modeling and making a mobile apps probably in current advancement of AI ML is maybe possible. So if we are able to get the all type of drugs and their parameters, we can predict the drug interaction and adverse effect. Along with that, we can also do the precision meaning, like you can genetic markers also. You can see that is there any alteration of metabolism is there or not, or as you know that this age group lots of drugs are there, which is whichever the not required, de-prescribing is very much important, which can also suggested many times. Actually multiple patient is visited actually three four department, and everywhere I see that there was a PPI is one places it is pantoprazole is prescribed, another places it is omeprazole is prescribed, and patients are actually buying all the medications. So these things actually even without AI also it can detect it. Along with that, these drug interactions level within a renal functions, which is if we are able to build a models and others, lots of studies are also going on. Maybe after within few 1 or 2 years, we can get some models also. So where we can actually helping in a geriatric prescribing and precision medicines. So at the end, so what we can say is that with these all the parameters, like, and we know that there are lots of factors is there which actually can affect. So what actually our take home message, what we can actually do? So whenever we are prescribing, we have to think that what are the factors which can alter the PK, and as PK alter, PD also can alter. So we always have to think in each geriatric patient as an individual therapies. Most important is the renal function. So always before starting therapies is you have to check what is the renal functions, because renal function compromises the most common things. Then you have to check all the prescription, whatever the drugs are there, all the prescription you have to check. Whatever repetition is there, you have to eliminate. Then you have to check what are the potential high risk group is there, like, which can neurotherapeutic index drug like lithium, digoxins, warfarin. In these drugs, if possible, those drugs which we are doing therapeutic drug monitoring, those we have to identify. We have to check that is that necessary to give or not. If necessary, also what is the dose we can give. Those things we have to check. Then we have already potential list is also there based on our whichever department we are actually following. Whatever drugs they are mainly using, they can use the BS and stop and start criteria to minimize the harm. So they can check their all the drugs, or otherwise we can, what another thing can done is the clinical pharmacology OPDs. We can start, we can check all these medications, or otherwise specifically geriatric OPDs is there. There also they can do this checking and using that red alert to the physician, so that that can be changed. Another important is that as we know that there is a change of sensitivity and specificity, and these drugs we can start, if new drug is started, it should start at a very low dose and titrated cautiously. Initial phases for these patients specifically, we are required to 1 to 2 weeks monitoring. And if there was a possible pharmacogenomic studies, but it is not only recommended for geriatric patients, it is for all. We can do the precision medicines, and if we are able to collect the data in these areas, so if we are able to develop the app, then we can also actually de-prescribing strategies also we can start. So this is my take on this. Thank you. Any questions? So these are my referencing, along with that Goodman, Gilman and Harrison's I take actually. So any questions?
Okay. Yeah, thank you. And really, it is very, very informative topic. And most of the clinical trials, they are done in relatively middle-aged population, although they say 18 to 80 or 85. But the average age, if you see the demography, you will find it is around 45 to 55. That is the age range for most of the new drugs developed. Okay, they deliberately probably avoid the extremes. But when you prescribe a drug has been approved, new drug found to be very safe, effective in that trial population, then it comes to the market, and most of the clinicians will be thrilled to prescribe it in their population. They just take it home that the drug is approved by the regulator, means it is safe and effective, so they will start prescribing in all patients. Of course, pediatrics are not indicated, but adult patient means if it is approved for adults, it will be taken for granted that it is safe in adults. But as you mentioned that certain drugs are always low narrow therapeutic index drug or low safety margin, so you have to be very, very careful, especially with the new drugs. And of course, we should take the patient as a whole, not as a segment of cardiology or neurology or nephrology or gastroenterology. He should be treated as a whole subject, and he must be viewed holistically. What are the medications and what are the possibilities of interactions? So definitely there is a big risk, but we don't have much choice in elderly population. Okay, then one thing you have mentioned that the phase 1 metabolism, oxidation reduction is affected. But I got a reference in average clinical pharmacology book which says up to 85 years, there is no big change in oxidation and reduction profile of drug metabolism. So then we don't have any Indian data, so we have to see at what age our this metabolic changes happen. Of course, there is a possibility that those who have liver damage, particularly this hepatitis or cirrhosis, definitely there is a risk. And nephrotoxic drugs use, we have to check the creatinine clearance and renal function test. So these are essentials of prescribing, but we also see what are the cardiovascular reserve, what is the cardiac output, if there is a failure, or what is the status of this nutritional status, and of course the mental status. They have memory impairment, particularly after 75, 80, some degree of memory impairment happens,
Yes.
and they live lonely life. So whenever they come to the OPD for consultation, they start talking the entire story. So you have to pick up what exactly the problem is. So they will start talking about everything that they have because there is nobody to listen to them. So whenever
Yes.
they get some sympathetic ears, they start expressing themselves to the maximum. So that you have to pick up what exactly the problem is. Then of course, organ dysfunction along with disease burden, we have to survive. And you have rightly pointed out one very interesting point, start low and go slow so that you can optimize the therapy. And this is what is more needed. And antibiotics, we have very limited data from India. Antihypertensives, yes. One more thing I like to add for antihypertensive, that there is a condition known as pseudo hypertension. The patient is prescribed 2 or 3 antihypertensives, and when you measure the blood pressure, we are taking that indirect blood pressure measurement by compressing the brachial artery, and you will find that blood pressure is not reduced. So again, there is a tendency to prescribe higher doses or addition of more doses. Then you find that he is having frequent falls and he is having this blackouts. The reason being, there is possibility of an arteriosclerotic change in the blood vessels, for which you need to apply more pressure to compress the brachial artery. So that point has to be remembered. So that is pseudo hypertension. So this is a big issue, particularly those above 75. So this point is need to be remembered. And for antibiotics and immunosuppressants, anti-cancers, you have to individualize the therapy. We don't have much choice on
Yes.
that.
Yes, sir. Those way
Right.
we don't have a choice, but like a symptomatic management, what I feel is that many times symptomatic management within a lots of medication everywhere and along with the vitamin, with many actually think that vitamin will not affect any of these medications or metabolism. That is
True.
maybe it is cost. It also increase along with that, sir. That drug interaction potential and others are also increased. And sir, over the counter drug actually, what is actually many times we see they are taking some of the.
Self-medication, herbal medication. So they will
So,
continue. We
with
cannot
permission from
control
Hota
that.
sir, Hota sir, I just want to say something because I want to congratulate first Dr. Mondol, Soubitra Mondol, for this wonderful deliberation, and all the chairpersons. Due to lack of time, we don't have any much more discussion time.
Yeah.
Now, on behalf of IPS, I just want to thank Professor Devashish Hota, Professor Shantanu Kumar Tripathi, and Professor Shoilendra Handu sir for wonderfully moderating this session as chairpersons. We are really grateful to all of you, sir. And we are really thankful to all the speakers, starting from Dr. Uh, 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 Soumitra Mondol to Dr. Manjunath to Dr. Rachna Rohilla
Rachana Roila.
for their beautiful deliberation. Now we have with us Dr. Payodhi Dor, the organizing secretary of Indian Pharmacological Society National Conference this year, 2026, Kolkata, hosting this conference. So may I request Dr. Payodhi Dor to say a couple of words? for our delegates. And almost we have more than 500 delegates today. So over to
Right.
Dr. Thor.
Okay. Thank you, Dr.
Thank,
Sambo. Okay.
thank you. Thank you. So, once again, thanks, Pranam, my pranam to our respected teachers, seniors, and best wishes to the colleagues. So, as we are running really late, I just want to convey greetings from IPS, Indian Pharmacological Society, West Bengal chapter, and the Eastern India. So, we are conducting the IPS CON, National Annual Conference of IPS, as well as that is one of the most important international pharmacological conference of this part of the world. I welcome you all by 15th April. That is a very auspicious day to all of us. On that day, that's Poila Boishak, the day we start our new year. On that day, we are going to inaugurate our brochure, and we are having a special offer of early bird for a longer time. That is from 16th of April to 15th of August. We have categorized it among students, residents, IPS members, IPS non-members, international delegates. Apart from that, there are scopes for bulk registrations and many others will be there. In this conference, we will not only get the scope to learn about pharmacology, the core subject, but also you will get avenues of networking, avenues of meeting the industry, avenues of knowing the stalwart research scholars, avenues of knowing what is happening in medtech world, in AI, in compliance scenarios, what are the new upcoming things in quality, compliance, and vigilance arena. So it is going to be a comprehensive conference where the theme is patient-centric pharmacology. We are talking about primarily focusing on a patient as a comprehensive case, as a comprehensive human being, and how pharmacology being at the center of it may help to deliver a better quality of care and science. When by care we mean C for clinics, A for academics, R for research, and E for ethics. With these few words, I will request all of you to be ready. And as we know that election is going on right now in West Bengal, so though we have booked the venues, it's very difficult to confirm the exact venues right now before the election result is over because those are the government properties. So we'll come up with the exact venue, and that will be a surprise to I hope. And we are looking forward a very culturally steep, culturally enriched, very academically empowering, and technologically elevating conference we are looking forward. So on 15th of April, that is on this Paila Boishak, we'll inaugurate the brochure. We'll love to see all of you. We'll request our seniors to enthuse your juniors, your colleagues, whomever you know who is related to pharmacology, to come and join us in this largest Medifest of pharmacology of the year. Thank you. Thank you so much.
Thank you, Dr. Thor. Now, may I request our president, Professor Babul Bej Borua sir, to have his valedictory address.
Thank you, Sambo. It was a nice this one presentation by most of because I have joined in the half of the session. I have gone through the last and last but one middle in the middle of the session. I didn't know that Professor Hota was so a delightful moderator. Santanu sir is there, though his aging is going on, but nobody knows that he is still now more than 70 plus. But just it's our pride. Basically, for me as a president of IPS, to address you on this occasion. And every one of you know that pharmacokinetics, as you well know, form the backbone of rational therapeutics. So a clear understanding of how drugs are absorbed, distributed, and metabolized and excreted is very much essential for ensuring the safe, effective, and individualized patient care. So, on behalf of the Indian Pharmacological Society, I extend my sincere appreciation to the organizers, basically Sambhu, because he is very much enthusiastic in this regard, and for his excellent efforts in conceptualizing and successfully conducting this workshop. And also my heartfelt thanks goes to the distinguished speakers and resource persons whose expertise and insights have greatly enriched this workshop. And you know that workshops like these play a vital role in strengthening our professional competencies and also keeping us aligned with global advancement in pharmaceutical sciences. So, as a member of the healthcare community, it is our collective responsibility to ensure that our knowledge translates into better healthcare outcomes for society. And that's why I urge all the participants to carry forward the knowledge and skills acquired here into your professional practice, your research, then and academic pursuits. Let this workshop not be the end, but rather a stepping stone towards continuous learning and innovation. Before I conclude, I once again congratulate the organizer and participants for making this workshop a grand success. As Sambhu has told that more than 500 participants are there. So I wish you all continued excellence in your future endeavor. So with these words, I declare this pharmacokinetic workshop formally concluded. Thank you. Jai Hind.
Thank you, sir.
Thank you, sir. Thank you very much, sir.
Thank you very much.
Good
Thank
night.
you.
Pranam.
Thank you very
Good night.
much.
Good night.
Goodbye.
Thank you. Good night.
So, time to log out then.
Payodhi,
So,
Yep.
is
Thank
is
you.
Yeah,
Payodhi
Swastika
there?
will say something now.
no, sir, actually, I was about to close the session
Yeah.
officially.
Okay.
So, thank you so much to all the dignitaries present here. Clarity is really glad to have all these brilliant people together in session today, and I really hope that you all had a seamless experience. So, with everyone's permission, I'm now concluding the session in here for today, and looking forward to have you again very soon.
Thank you.
Thank you so much. Have a great evening.
Thank you. Thank you.
Thank you.